Yeah, we're live on YouTube. I think we can begin the session. Good morning, everyone, and welcome to today's webinar. And it's a wonderful sunny Sunday morning, and we are already into March, and we're seeing less number of COVID cases now. Hopefully, the pandemic is behind us, and it's time for us to go ahead with gratitude and also hope.
Hello.
Morning, everyone. I'm so sorry, had some technical issues, and I think we are now back. Bhaskar sir, can we begin?
Yeah, please go ahead.
Yeah. So, morning, everyone, and welcome to today's IIP Twin Cities Brand Symposium. A warm welcome on behalf of the entire executive board, and it's our endeavor on behalf of IIP Twin Cities branch to reach out to all the pediatricians with the recent trends related to the subspecialties. And this month we are dealing with pediatric nephrology, and we have a wonderful team of experts to share insights on common pediatric conditions related to the renal system. IIP Twin Cities branch requests your support, and it's our endeavor to ensure that we're able to continue the series of academics. I now request our president, Dr. Sunkoj Bhaskar sir, for his remarks, and then we can proceed with the session. Dr. Bhaskar sir, please.
Yeah, thank you, Dr. RSV. I know Dr. RSV hardly slept for probably 2 or 3 hours last night. He's been working on several activities of IIP Twin Cities branch and as well State Telangana. Thank you, RSV, for helping academy so much. ST members of the faculty, Dr. Mehul Shahji, Dr. Himesh Burman, Dr. Nivedita Kamath, Dr. Pankaj Deshpande, Dr. S. Sri Krishna, and Dr. Lakshman Garlapati. The respected seniors, distinguished participants, ladies and gentlemen, good morning and welcome you all to this third IPTCB Symposium, which we have been doing since January. First one was on genetics, the second one was on pulmonology, and this is the third one. And our plan and action plan is to do these activities every month until December 2022. Our activities are, one is this Iaptcb Symposium on first Sunday of every month. Then on first Wednesday of every month, we have Iaptcb clinical meeting wherein we will be discussing on 4 short cases with presenters and experts. And thirdly, we have Iaptcb PG clinics. That's on third Sunday of every month, wherein a resident will be presenting a long case, and that would be discussed again by the lead experts. Lastly, we are planning to have a physical CMEs. Until recent past, we could not do it. We are going to do it. Why I'm telling all these things is, all these are possible with the support of experts and great academicians like Dr. Mehul Shaji, and many more stalwarts are there in Telangana state, particularly in Hyderabad. And as well, we are getting good support from people like you, the faculty members from across the nation. I think I'm always excited to talk about Dr. Mehulji because I love to speak good things. I love to avoid negative things, negative aspects for any discussion anywhere. About Mehulji, I can say that ever since he had come to Hyderabad, he had changed the face of the pediatric nephrology among the pediatricians, nephrologists, and even among the children and parents. We all know that he is a great academician, a great teacher, and an astute clinician. And fortunately, believe me, we are all, we have a CME every day from Dr. Mehulji because we keep referring our nephrology cases to him. And the feedback is a CME. Feedback that he sends to us is a CME for us. The way he presents, it covers comprehensively and really it gives a lot of information. So we love to send our patients, even the simple cases, we try to take his expert views, not to miss anything and to learn something. And he's a role model for many of us for his humbleness and respecting his colleagues the way he respects. So thank you, Dr. Mehulji. And lastly, he is the manager and captain of this team of pediatric nephrology. It seems Dr. Mehulji loves cricket so much. Even the entire pediatric, the program of the symposium is mixed with the cricket terminology. So thank you so much, sir. And nice to have faculty from various parts of country. Particularly about Dr. Barman, we always love to have faculty from Northeast. And fortunately and unexpectedly, we have you on our panel. I'm thankful to you and thankful to Dr. Mehulji for choosing you. And we always love to visit in Northeastern part of India. Whenever there is an occasion, academic occasion, we'll come and meet you in Shillong. And Dr. Pankaj Deshpande ji, Hyderabad is known for custard apples. Not only custard apples, Hyderabadi biryani, Hyderabadi chai, then pearls for our women and our hospitality. Thank you, madam, for participating from Bangalore. And also, this presentations which we are going to have today will be published in our Iaptcb monthly journal, which will be released on next symposium, that is on next Sunday of the next month. So kindly, I request you all to send your abstracts to Dr. Mehulji so that we'll publish them in our journal. And one good news is IAP Telangana State and Twin Cities branch is awarded to organize IAP Central Zone Conference, which comprises of 5 states, that is Uttar Pradesh, Madhya Pradesh, Chhattisgarh, Telangana, and Andhra, which we are doing in the month of June on 10th, 11th, and 12th. So I request all of you to support us academically, to participate actively. I request all the participants, the distinguished participants, to participate in this big, a mini national conference. The reason for choosing UTI was, UTI is not uncommon and many times it is missed. Not uncommon and many times it is missed unless we always remember it and keep it in our suspicion. As we all know, it's a hidden cause for many illnesses, starting from anorexia to chronic conditions like failure to thrive, recurrent fevers, so on and so forth. So for that reason, I had focused on subspecialties every month, but this time focused on another subspecialty of the subspecialty, that is UTI. So with these words, hope all my colleagues who are participating will have a great learning experience. So thank you all once again. Very shortly, Dr. Sanjay, our Editor-in-Chief Journal, will be making few remarks along with Dr. Vinith Saxena, our Honorary Secretary General, will be releasing our journal of March. So thank you once again. And this program is being coordinated by our senior colleague and future president of Iaptcb, is Dr. Lakshman Garlapati. So over to Dr. RSV.
Thank you, sir. Thank you. So what we've had so far, and this is in keeping line with the theme selected by Dr. Mehul and the team today, is the opening remarks by the referee, Dr. Bhaskar. Now I'll hand it over to the umpire, Dr. Lakshman Garlapati, and we have the toss ready and the batsmen ready and the bowlers ready. I'll hand it over to Dr. Lakshman, sir. So to please take it forward. Request the players for just about 5 minutes of drinks break between the innings, so that in that drinks break, we have a small journal release. I promise that we'll not interrupt the batsmen's sixers in between. We'll ensure that we'll do it only after the talk is over. So hand it over to Dr. Lakshman Garlapati. Sir, it's all yours.
Yeah, thank you, Dr. RSP. Thank you, Dr. Bhaskar. Good morning, everyone. And good morning, distinguished speakers. And at the outset, I thank all the speakers, the eminent speakers, for this kind participation in this morning symposium on nephrology, more on UTI. And here we are having 4 speakers. Dr. Himesh Verma, who is an associate professor and HOD, NEIGRI HMS Shillong, and from Meghalaya. And we can see the background of Shillong, the Meghalaya. It's a very nice place. We would like to visit, sir, Dr. Himesh, and who would be speaking on diagnosis, microbiology, and predisposing factors of UTI. And followed by Dr. Nivedita Kamath, Associate Professor in Department of Nephrology, St. John's Medical Hospital, Bangalore, would be speaking on management of UTI, including prophylaxis. And third batsman is Dr. Mehrul Shah. Everyone knows in Hyderabad, our Dr. Mehrul Shah is a pediatric nephrologist who is associated with Apollo Hospital and Little Star Hospitals at Hyderabad. We have been associated with him from last 20 years, and who would be speaking on imaging studies in UTI. And last batsman, only four batsmen are there. Last batsman is Dr. Pankaj Deshpande, who is a consultant pediatric nephrologist, Hinduja Hospital, Mumbai, and Apollo Hospital, Belapur, and who would be speaking on common errors in UTI and management and diagnosis. And followed by, we have a panel discussion with Dr. Sri Krishna. So now over to Dr. Himesh Burman. Sir, Dr. Himesh Burman.
Before Dr. Himesh starts, word from the captain, Dr. Mehul Shah, and then the first ball can be bowled. Dr. Mehul, please.
Yeah.
Yes, I'll just take 2 minutes. Once again, thank you, Dr. Bhaskar Garu, Dr. Lakshman Garu, and Dr. Sri Krishna for the opportunity to participate in this symposium. Dr. Bhaskar Garu always says good words because he himself is such a humble and nice person. I've been fortunate to have been associated with him and all of you over the last 22 years. It's really been an honor to work along with the entire team over here. Secondly, I think I would just excuse myself as not being the captain of the program today, I think the credit goes to Pankaj to make it an interesting theme over here. Pankaj has been a close friend for the last 32 years. We have done our pediatrics together in Wadia Children's Hospital, Bombay, and it was his idea to make it a little interesting for the participants over there. So thank you, Pankaj, for bringing out this nice theme. Nivedita, I know she's already been introduced, but let me share this with the group that she's the first DM pediatric nephrologist in our country. She's the first DM pediatric nephrologist in our country, and known her for the last 15 to 16 years. And it's a real proud moment when she became the first DM pediatric nephrologist. And Himesh, a young pediatric nephrologist, he's bringing up the pediatric nephrology services in Sikkim over there. And again, I have known him for the last 13, 14 years. So thank you once again, friends. And I hand over back to Dr. Sri Krishna. Thank you.
Yeah, thank you. So over to the first batsman, Dr. Himesh.
So good morning, everyone. So at the very outset, I would like to express my gratitude to the IIP Twin City branch for giving me this opportunity, Dr. Bhaskar, Dr. Sri Krishna, Dr. Lakshman, and Dr. Vamsi, and hope I live up to the expectations. So in this beautiful sunny morning, I have been asked by the captain to open the innings and to play with a straight bat. And that's what I will try to do. For an opening batsman, it's a task of responsibility to set the score good, lay the foundation so that a big score can be made. But in many ways, the job is easy also, because in case the opening batsman fails, then there are people coming who can cover for him. So with that, today my topic that is given to me is urinary tract infection, diagnosis and causative factors. So this I'll try to cover. Next slide, please. So to introduce the topic, UTI is one of the commonest bacterial infections in children. Our concerns in relation to UTI is the acute concerns like acute morbidity and the economical cost involved in it. But the major concern is long-term kidney complications like scarring, hypertension, ESRDs. So that's what we are worried about this. And it is one of the causes of occult bacterial infection in young children, and other causes include Haemophilus influenzae and pneumococcus. And as Haemophilus influenzae and pneumococcus infections, vaccines are getting more acceptance and more widely given, probably UTI is gaining a relative importance as a cause of occult bacteremia in young children. Next slide. So in this, I'll try to quickly discuss about a brief epidemiology. Why bother about UTI? We already discussed about that. Symptoms of UTI in children, risk factors, when to suspect, choice, timing, and interpretation of test, and confirmation of diagnosis of UTI. So then I'll begin with an illustrative case. Say, suppose a 2-year-old baby girl with high fever for 2 days. This baby has passed few semi-solid stools per day and is vomiting occasionally. From last night, the baby is irritable and not feeding well and looks sick when the baby presents to you. So I would request all the delegates to keep this case in mind. It's not that I'm going to I'm not going to take this case along my lecture, but I would want you to take 30 seconds to think that in such a case, what are the possible diagnoses you will keep in mind? What points you are going to extract in history and examination. And as I speak in my rest of the talk, I would want you to see whether I make sense in context of this case or not. Next slide, please. So risk of developing UTI before the age of 14 years is around 1 to 2% in boys and 3 to 8% in girls. And this incidence is age related. So in newborn, there is more chances in boys than in girls. In infants, it becomes more or less equal. And beyond infancy, girls are more likely to have urinary tract infection. And it is related to a shorter urethra in girls and a more likelihood of congenital anomaly in the boys. The diagnosis of UTI is often missed in infants and young children as urinary symptoms are minimal and often non-specific. So clinical features also may be related to the age and severity of the illness. So in neonates, we can have features like features of sepsis, lethargy, shock, unstable temperature, persistence of jaundice, non-specific features like failure to thrive, vomiting, and diarrhea, and foul-smelling urine. Whereas in younger children, we can have, again, non-specific features like recurrent fever, diarrhea, vomiting, poor weight gain. Unexplained fever may be the only symptom in some of the children. In older children, we may get localizing lower urinary tract symptoms along with fever. Now, if we try to look into the symptoms, because we talk about when we're approaching a fever case, we want to know where the symptoms are localizing to which system. So similarly, if we want to use symptoms to localize symptoms in a urinary tract infection, we can have either pyelonephritis or cystitis. And fever, flank pain, abdominal pain, vomiting, sepsis, these are some features that point towards a upper urinary tract or a pyelonephritis, whereas dysuria, frequency, incontinence, hematuria, these are some points that will point towards a localized to lower urinary tract infection. However, I want all of you to remember that this distinction is difficult and not necessary. So we should not bang our head to differentiate whether this is an upper tract or lower tract. And if a child who presents with a febrile urinary tract infection, we should assume that as pyelonephritis. So some more points to remember. Older children may have burning, micturition, urgency, frequency, and flank pain, but these features are uncommon in younger children. Symptoms restricted to lower urinary tract without fever may be seen in adolescents. So if somebody comes without fever, then we can see that in adolescents, but we don't see that in younger children. Children with higher fever and more than 39 degrees Fahrenheit and systemic toxicity, this group is called complicated UTI and rest is called simple UTI. Next. So when we are evaluating a child, we need to know the probability of this child having a urinary tract infection. We need to look for whether this child has any underlying predisposing factors or not. And the major predisposing factors include a underlying functional abnormality like bladder bowel dysfunction or a neurogenic bladder, or there could be a structural abnormality like posterior urethral valve, vesicourethric reflux, ureterocele, etc. So now, how do we know that if a child has any structural or functional abnormality? For that, we can have some clinical pointers, like if we have a palpable or distended bladder, palpable or enlarged kidneys, if we find tight phimosis or any valvular synechia, then palpable fecal mass in the colon, which indicates underlying constipation, patulous anus or neurological deficit in lower limb, indicating a neurogenic possibility of a neurogenic bladder, urinary incontinence, then previous surgery of the urinary tract, or anorectal malformation or meningocele. So these, if we find any of these in our investigation, in your examination or history, then that will point towards possibility of some problem in the your genitourinary system. Next. Right. Bladder bowel dysfunction, this is a very important thing to remember, and it is something that is a major contributor, a contributing predisposing factor in causing urinary tract infection. So what are the pointers for that? Children coming with recurrent urinary tract infection, we should always keep bladder bowel dysfunction as one of it as an underlying condition in mind. Persistence of high-grade vesico-ureteric reflux. We know that over the age, the vesico-ureteric reflux decreases in grade and ceases to ceases. If that doesn't happen, then we should keep possibility of bladder bowel dysfunction. If there is constipation or impacted stool, then again, if we see maneuvers to postpone voiding, like holding maneuvers, Vincent's curtsy, squatting. So if we see such maneuvers, then we should think of bladder bowel dysfunction. If a child is voiding less than 3 or more than 8 times a day, that again we should raise eyebrow. Staining or poor stream, this is another indicator. In an ultrasound, if we get a thickened bladder wall or increased post-void residue, so that's another indication. And in a micturating cystourethropography, there will be more details on that. But if we get abnormal pattern like a spinning top configuration, these will also in advanced stages of bladder bowel dysfunction. Next slide. So with this backdrop, when should we suspect urinary tract infection? So first important thing is that it can present like many other conditions. There will be a lot of overlap in symptoms, and therefore maintaining a high index of suspicion is very important. Next. So when to suspect? First is in younger children, if child presenting with fever without focus. So this is one group that we should keep urinary tract infection as a possibility. Then second, if we have localizing signs to the urinary tract, especially if it is associated with fever. So that is another scenario where we will keep urinary tract infection. And in both these scenarios, we would be looking for high likelihood scenarios of underlying predisposing factors like past history of UTI, known structural abnormality, signs or symptoms of functional or structural problems. So if we have this, then the likelihood will be more. Next, please. So in fever without focus in children, we may have up to 5% of these children may have urinary tract infection. And as I was saying, that as there is less and less we get children with Haemophilus influenzae and pneumococcus, then there is a possibility that the proportion of urinary tract infection as a cause of fever without focus may slightly increase over years. Next. Then looking for high likelihood scenarios. So we should suspect UTI if there is a past history of UTI, if there is presence or there is a likelihood or any indicator or possibility of Kub anomaly, absence of another source of infection. So if we find that there is another source of infection, for example, a child with fever has also running nose and cough, then we know that there is another focus. So then our chances of urinary tract infection will be low. But if we don't have another absence of another focus, we should again think of possibility of UTI. And fever without focus, especially with high fever, we should keep in mind. And if fever is lasting beyond 2 days, then again, we should keep UTI in back of our mind. Pointers for Kub anomaly, this is just a quick recap we have already seen. So if there is constipation, bladder bowel dysfunction, so that's a thing, then we have an abnormal antenatal scan may be available, abnormal previous scan done for any other reason may be available, poor stream may be available. If there is poor stream in boys, that may point towards a bladder outflow obstruction like PUV, then we can have markers for extrarenal malformation like bacterial association, which may indirectly indicate that there could be an underlying renal malformation as well. If there is any spinal defect, if neurodeficit in lower limb, or if palpable bladder or kidneys, as we have discussed earlier. So if we had anything of this, then it increases the likelihood that the child could be having UTI. Now, there are certain scenarios where there is lower than average likelihood, like the rate of circumscribed boys is 4 to 20 times lower than that of uncircumscribed boys. And presence of another clinically obvious focus of infection reduces the likelihood of UTI by half. Next. Now, here there is I'm trying to create a conceptual framework summary of approach to a urinary tract infection. So first, we will have to extract the clinical, see the clinical presentation history and examine. And then this will give us a probability of urinary tract infection in this child. Now, once we have suspected urinary tract infection, then we will do the diagnostic test. Then in this situation, suppose we fail to suspect, then that there is a missed opportunity to diagnose. So a child was there is possible UTI, and there was a missed opportunity to diagnose. Once we have done the test, then we will have a revised probability of urinary tract infection based on whether we have a positive or negative test. And this, when we are looking at interpreting tests, we have to keep in possibility of misdiagnosis like false positive and false negative results. Next, then with this, we have a once we have established or confirmed the diagnosis of urinary tract infection, so we give the acute treatment for the urinary tract infection, and then next we will go on to evaluate for picking up underlying anomaly. And if we can efficiently complete the whole cycle, then we would be able to probably prevent renal damage to some extent in long term. So yes, sir. Then So my talk is on diagnosis. So just try to outline the principles of diagnosis. So again, recapitulating, urinary tract infection is nothing but invasion of urinary tract by pathogens, and it is identified by growth of a significant number of organisms of a single species in the urine in presence of symptoms. So here, points to remember as if there is a growth of significant number and single species and presence of symptoms. So these are important. So again, that means it brings us to this sort of a triangle where we can think that the essential part of this triangle is symptoms. Fever is the most important of that. Then presence or demonstration of bacteriuria, which is most importantly demonstrated by growth in the urine culture, but indirect indicators include presence of nitrite in urine or presence of bacteria in gram stain, and demonstration of pyuria, which is seen by a routine urine examination, but leukocyte esterase is another test that can give us an idea. So for urine microscopy, we have two types of tests where we can have an uncentrifuged urine, where if we get more than 10 WBCs per cubic mm, that is significant. And if we are doing centrifuged urine, then more than 5 WBCs per high power field is significant. So of this, the uncentrifuged urine is more labor intensive, but it is more suggestive of a urinary tract infection. The sensitivity is more of a uncentrifuged urine, but most labs report a centrifuged urine report, and the significant value for that is more than 5 WBCs. Fallacies in this is that it cannot be used alone for presumptive diagnosis of UTI, because there are causes where there can be pus cells in the urine without a urinary tract infection. This include as simple as fever can be a cause of sterile pyuria. And we also need to keep in mind that in some leukocyte lyses rapidly, especially if the urine is alkaline, and if the microscopy is delayed. So that may give us a false negative in certain scenarios. What is the role of dipstick test like leukocyte esterase and nitrite? So this provides for screening and rapid provisional diagnosis. It aids in early clinical decision making for use of antibiotic in certain scenarios. And leukocyte esterase has more sensitivity. Leukocyte esterase has more sensitivity, but it's not specific. The advantage is that the pre-laboratory error where there could be leukocyte lysis that leads to a negative urine microscopy, even in lysed WBCs, leukocyte esterase can come positive. So that's an advantage. Nitrite has more specificity, but in younger children, you need 2 to 4 hours of time for contact time for nitrates to convert into nitrite, and therefore these babies keep on voiding frequently, and the specificity of urinary tract infection could be low in these cases. But in a child where if we are suspecting UTI and both these comes negative, then urinary tract infection is very unlikely. Next. Now, however, this is a presumptive diagnosis, but a positive urine culture in a symptomatic child is the gold standard for diagnosis. And for that, when the significant colony count depends on the type of sample that we have sent for culture. So if a suprapubic aspiration is done, any number of pathogen is significant. If a urine is collected by urethral catheterization, then more than 5 × 10⁴ CFU is significant. And if a midstream clean catch is done, then more than 10⁵ is colony forming unit is important. For collection of sample, a clean catch midstream can be used in older toilet trained children. It is difficult to collect and unpredictable in young ones. So if we want to collect a midstream in a young child, there can be undue delay in collecting a sample. And as we know that we need to collect the sample before we start on antibiotics. So there could be an undue delay in starting antibiotics, and that may lead to a problem in the outcome. Bag samples are unsuitable for culture. This is very important, that if urine is collecting for urinary your bags, then it should not be collected sent for cultures, and it can be used for urine analysis though. And if in case it is sent, its only significance is if we get a negative culture, that is significant, but positive cultures will have no meaning if a sample is sent for bag samples. Suprapubic aspiration or catheter samples should be collected for culture in younger children. And while doing so, we must use sterile technique. First is for prevention of any hospital-acquired infection in the children. But more importantly, and this is a golden sample, because once we have collected this sample and we have sent the sample for started the child on antibiotic, if there is a contamination, we practically cannot repeat it, because we would have lost the window for sending a urine culture again. So it's a golden sample. We must use a sterile technique and not cause contamination. In urine culture, specimen should be promptly plated within 1 hour of collection. If there is a delay in sending to the lab, then it can be stored in refrigerator at 4 degrees centigrade. That means in the door of the refrigerator for up to 12 to 24 hours. A urine culture should be repeated in case contamination is suspected. So that means a mixed growth of 2 or more pathogens, or growth of organism that normally constitute a periurethral flora. Like you can have lactobacilli in healthy girls, or you can have enterococci in infants and toddlers. So these could be contaminants. Next. Now, this is another important concept of asymptomatic bacteriuria. Sorry for the spelling error. So presence of significant bacteriuria, that means the counts that I have shown, significant bacteriuria in absence of symptom of urinary tract infection is asymptomatic bacteriuria. And asymptomatic bacteriuria is a benign condition which does not cause any renal injury and requires no treatment. Organisms isolated in most instances for asymptomatic bacteriuria is E. coli, and which is of low virulence. Now, I'm coming towards the end of my talk. And this is a quick interpretation matrix for urinary and cultures and symptoms. These are the 3 points on which we will make a diagnosis. So if a child is having symptoms and the culture is positive with or without a positive urine analysis, then this is urinary tract infection. Why with or without urine analysis? Because normally we will have urine pus cells also positive, but for practical reasons where there can be a pre-laboratory delay and lysis of cells, sometimes it may come negative. And that's why the ISPN guidelines have fall short of recommending that there should be urine pus cells also. So symptoms with or without pus cells, but culture positive is urinary tract infection. If there is no symptoms and then urinary culture is also negative, then this is not UTI. Sometimes coincidentally, parents can bring reports of culture and urinary for an opinion. So this is not urinary tract infection. If there is symptom, but urinary and culture is negative, then also this is not an urinary tract infection. But we need to keep in mind the fallacies of false positives, false negatives of culture and false negatives of urine analysis while interpreting these cases to be not having urinary tract infection. Then if there is no symptoms, but urine culture has come positive, then this is asymptomatic bacteriuria. And with or without symptoms, if there is urinary is positive for pus cells, but there is urine culture is negative, then this is sterile pyuria. So sterile pyuria could be as simple as fever. You can have sterile pyuria in nephrotic syndrome or other glomerulonephritis. You can have infections of the urinary tract infection other than bacteria, like viral infections, fungal infections, tubercular infections, and all these all could be causes of sterile pyuria. But remember that fever itself can cause some pus cells in the urine. Next. So to summarize again, so we will bank our diagnosis on these 3 cornerstones. We have to have a symptom of urinary tract infection. Fever is the most important of that. Then demonstration of bacteria in the urinary tract infection. Culture is the most important of that. And demonstration of pus cells in the urine. So there are certain things that we will keep in mind, that fever may sometimes be not present at presentation in cases of immunocompromised patients, or if there has been prior antibiotic has already been used. So again, similarly for cultures, if there can be some false negatives, again, collection errors, prior antibiotic use, contaminants can be there, asymptomatic bacteriuria can be there. So we need to keep these in mind while interpreting that. And while for pus cells, we again need to think about leukocyte lysis because of delay. Then immunocompromised children sometimes may not be able to mount an inflammatory response, and therefore pus cells may not be present as expected. And we need to keep sterile pyuria as one of the thing in our mind. So we need to interpret these tests and symptoms in light of the clinical context. Next slide. So take home is that suspect UTI in an appropriate clinical scenario, look for underlying predisposing factors, ordered appropriate tests and appropriate samples. Samples needs to be sent appropriately. Urine culture positivity is the cornerstone for diagnosis of UTI, and use Dipstick for early decision making, but it's not diagnostic. Wait for the culture for confirmatory diagnosis. Thank you.
Dr. Lakshman? Dr. Lakshman? Dr. Lakshman, are you available? Yeah, thank you, Dr. Himesh Burman. It was a wonderful presentation. We love to have it, and we want to hear for some more time, but due to time constraints, we are unable to request you to continue your further talk. But the presentation was very good, very useful, precise, and crispy. Thank you very much. Now, over to Dr. Mehulji.
Okay. Thank you, Himesh. It was a wonderful and lucid presentation. I think you took us. Hello?
Yeah,
Am I audible?
Yes, sir.
Yeah, so thank you. You took us to the diagnosis of UTI, and more importantly, when not to think of UTI and when to treat UTI, even if the culture is negative or the pus cells are not as per the definition. I think we'll move on and we'll take the questions together. I now invite Dr. Nivedita Kamath. She's an associate professor in Department of Pediatric Nephrology at St. John's Medical College Hospital in Bengaluru, and I invite her to discuss about the management of a child with urinary tract infection. Nivedita, please.
Thank you, sir. Thank you for the invitation, and thank you for the kind words of introduction. We have had a long association with Mehulcha sir, and I remember he used to come to Bangalore often whenever we organized a CME. Unfortunately, now for the last few years, we have not been able to. And thank you, sir, for being associated with us and our department and for giving me this opportunity. Also, thanks to the IEP Twin City branch for giving me this opportunity.
Thank you.
My work has been made easy by Dr. Himesh, who's presented very well on the diagnosis, because UTI is one infection in children which is always fraught with controversies and confusion. So the diagnosis of UTI has been made very clear by Dr. Himesh in his previous presentation. So let's look at the management of UTI. If you look at different reviews, guidelines, meta-analysis, probably your head will be spinning as to what you should do in this particular child with UTI. To sweep this spin and to make things a little more clear and easy, let's look at what we can do to manage a child who has already been diagnosed with UTI. The common clinical conundrums that we face, as Dr. Himesh also has elucidated in his previous talk, is a young infant, say a 3-month-old boy who's presenting with fever without focus and has a culture that is growing a significant colony count of E. coli. A second situation may be a toddler, a little older child, a 3-year-old girl who's present with fever and crying while passing urine and a significant growth. We have heard in the previous talk that symptoms and positive culture is very important for making a diagnosis. 13-year-old girl with perineal itching and whose culture also is positive. So how is the management going to vary in these three scenarios, and what are the different risk factors that we need to look for, and how do we need to evaluate these patients for the future? So the first question is it UTI? So we have already heard a lot about it, so I'll just quickly go through this. As Himesh also said, it should be in the presence of a significant colony count of a single organism and the presence of symptoms. So to remember these three S's whenever you're treating a child with UTI, or rather before you start treating a child with UTI. So let's take two case scenarios. One is a 3-year-old girl, has some foul smelling urine, perineal itching, urine culture shows growth of E. coli. But if you ask the history in detail, you might find that the sample is improperly collected and she has never had any fever. So is it really UTI? That needs to be seen before started antibiotics. In contrast, a 3-year-old girl with high-grade fever without focus comes with a febrile seizure. Initially, CNS infection is suspected and a lumbar puncture is done, which is normal. And later on in the evaluation of the cause of fever without focus, a urine microscopy is done, which shows 400 WBCs, but the culture shows no growth. So is this UTI? The problem here is, again, if you look at the history carefully, you will find that the culture was sent 2 days after starting the antibiotics, because this child came with febrile seizures and a high-grade fever without focus. So antibiotics were sent before antibiotics were started before a urine culture was sent. So in this case, one might have missed the diagnosis of UTI. So it was stressed in the previous presentation, the golden window period should not be missed, and the sample should be collected appropriately by giving the patient appropriate instructions, or if we are collecting it ourselves, using a sterile technique. The next question is, we have confirmed the diagnosis. What antibiotic do we start? Which route? When do you start it? And how long do you give it? Now, this is something that we need to understand. That is whether the UTI is simple, which means it's associated with low-grade fever, and it's typically located only to the lower tract. Dysuria, frequency, urgency, which are symptoms of a bladder involvement, may be present, or whether it is complicated in the sense that there is high-grade fever, systemic features, renal angle tenderness, or abnormal creatinine, which case it mostly points towards a pyelonephritis or an upper tract involvement. In a young infant, as we have already discussed, it is more likely that this child has a upper tract involvement or a pyelonephritis, especially if there is fever without focus, a toxic looking child, features of sepsis or shock, and sometimes there may be non-specific features like diarrhea or jaundice. The urine culture, of course, is key. In a complicated UTI, always initiate therapy immediately after sending cultures, preferably IV antibiotics for 3 to 4 days, followed by oral antibiotics for 7 to 10 days. The drugs of choice are third-generation cephalosporins and aminoglycosides. Now, if you look at the guidelines, they will probably say that there will be a lot of confusion because different guidelines recommend different therapies. If you look at the American Association of Pediatric guidelines or the NICE guidelines or the Indian guidelines, they are all different. The AAP and the ISPN guidelines recommend antibiotic therapy for 7 to 14 days in a child with a suspected pyelonephritis. And in the NICE guidelines recommend only for 7 to 10 days. However, there is no real evidence to suggest whether 7 days or 10 days or 14 days is better. Oral antibiotics and IV antibiotics have been found to have equal efficacy in treating pyelonephritis, but in a sick child, a child who is not able to take orally, who has features of sepsis or systemic features, one would definitely, at least for the first 3 to 4 days, prefer IV antibiotics. And then depending on the response of the child, you could change to oral antibiotics. So that is the treatment of a young infant with suspected pyelonephritis. In an older child, it is likely that the child has a lower tract infection, but definitely pyelonephritis also could be possible. So looking at the fever, like this 3-year-old girl who presented with low-grade fever and some features of lower urinary tract involvement, like crying while passing urine and dribbling, is most likely having a cystitis. This is a simple UTI. There is no systemic features. There is no abnormal creatinine, no renal angle tenderness. The child is otherwise quite stable and comfortable. One could definitely treat with oral antibiotics. The dictum here again is to initiate therapy after sending culture. The oral antibiotics, again, the treatment duration is varied in different guidelines. Most guidelines now recommend for a lower simple urinary tract infection, antibiotic therapy for 3 to 5 days. But the ISBN guidelines, these are of course slightly older guidelines of 2011, which are likely to be soon revised and will probably shift to the 3 to 5 days. But as of now, the guidelines recommend 7 to 10 days. But most other guidelines recommend 3 to 5 days. So 5 to 7 days of oral antibiotics should be good enough. And again, third generation cephalosporins, amoxicillin clavulanic acid combination and fluoroquinolones are the drugs of choice in this category of patients. What about this 13-year-old girl with perineal itching and a culture positivity? As we just heard in the interpretation matrix that was given by Dr. Himesh, this girl is most likely to have a asymptomatic bacteriuria, because perineal itching is typically not a sign of UTI. It is probably some local infection. So a thorough history and examination needs to be done. Urine microscopy, which is most often negative because these are colonizing organisms that are grown and are not really pathogenic. So the urine microscopy is unlikely to show signs of inflammation. No treatment is required in such a case. But of course, only after a thorough history examination and looking at the urine microscopy can one come to this conclusion. The risk of treating these children with asymptomatic bacteriuria is that we increase the risk of resistant organisms. What are the choices of antibiotics that we have? As we discussed, the third generation cephalosporins and aminoglycosides are recommended by most guidelines. One should always look at the culture sensitivity patterns in your hospital before you make a choice between these two. Amoxicillin clavulanic acid could also be used. The oral antibiotics, again, are third generation cephalosporins, amoxicillin clavulanate, and fluoroquinolones are also listed in this. A few common questions that are either asked to us by clinicians or sometimes by our resident. Like, for example, a urine culture sensitivity is grown E. coli. You've started the antibiotic, say third generation cephalosporin, but when you get the culture sensitivity report after 48 hours, this E. coli is only sensitive to nitrofurantoin. So should we change the antibiotic to nitrofurantoin? One must keep in mind that nitrofurantoin achieves poor concentration in the kidneys. And if you're suspecting, if this is a young child, if you're suspecting a pyelonephritis, then it is not a good drug to add. It achieves good bladder concentration, so it is good as a prophylactic agent, but not as a treatment of a pyelonephritis. Child is treated with cefixime for 3 days. The urine culture sensitivity report shows resistant to cephalosporins and only sensitivity to aminoglycosides. So should we change the antibiotic? This again is a common clinical conundrum that we see in routine practice. Like most other infections, probably the clinical response should guide therapy, because we know that there could be some difference between the in vitro and in vivo sensitivity. So if your patient has responded in the 3 days of antibiotic therapy, though it is not sensitive, you could probably continue the same antibiotic therapy with careful monitoring of symptoms. However, if there is no good response or the expected response is not present, then definitely change to a sensitive antibiotic. Or if there is an underlying cause, such as an obstructive uropathy or anything that could cause a resistance to infection or a recurrence of infection, it may be advisable to change the antibiotic. The urine appears very turbid. Should this child be catheterized? Catheterization is generally not recommended unless there is a suspected obstruction of the urinary tract, or sometimes, especially in severe cystitis, not bacterial, but typically in viral cystitis, where there are large blood clots, we often need to catheterize to relieve the obstruction, because passage of these blood clots could be painful, and also they might cause retention of urine. So unless there are these scenarios, catheterization is not routinely recommended. This is just to recapitulate what we have already discussed. We know that in children with age less than 2 years, there are non-specific features, high-grade fever, fever without focus. In older children, they typically present with features localized to the lower urinary tract. In either case, whenever clinically a UTI is suspected, a culture must be done and empirical antibiotic therapy is started immediately after sending the cultures. If there is an insignificant or no growth, then it is probably not a UTI. If there is a significant growth of a single species in the presence of symptoms, a diagnosis of UTI is made. For a complicated UTI, 7 to 14 days of antibiotics. For uncomplicated, 3 to 5 days or a maximum of 7 days. And supportive findings are the rapid urine test like pyuria and bacteriuria, and sometimes maybe other radiological investigations, which we'll come to in a bit. What is the supportive care for UTI? IV fluids, oral hydration, controlling the fever, and usually these children do well in 2 to 3 days. We must identify those who are at risk of recurrent UTI and plan further evaluation based on the age and risk factors. Again, some of the common questions here are, UTI has been treated and a repeat culture has shown E. coli of 1,000 colony forming units per ml. So what should be done? This is probably one of the most important or most common reasons why UTI is referred to a pediatric nephrologist or urologist. At least that is what we see in our practice. A repeat culture is not indicated if the child is improving clinically as we expect the child to. It should be considered if there is a refractory infection or prior to an invasive procedure like an MCU or a cystoscopy or a urodynamic study. Then definitely we need to ensure that the urine is sterile before we do this invasive procedure. So in a routine scenario, if the child is improving, there is no indication to do a culture. Should antibiotic prophylaxis be considered after treatment of UTI? So there are two indications mainly if we have to group them into two simple baskets. One is where there is a risk of recurrent UTI, and the other is the vesico-ureteric reflux. Antibiotic prophylaxis, of course, it seems quite simple that you just give a drug and you can prevent UTI, but there is most studies, especially in children with vesico-ureteric reflux, large studies like the RIVER trial, have shown that there is a high risk of getting a subsequent UTI with resistant organisms. So definitely antibiotic prophylaxis has the flip side of increasing the risk of resistance. So it must be cautiously used. What are the options for prophylactic antibiotics? Septran or cotrimoxazole, nitrofurantoin, and cephalexin are the three most common drugs used. Cephalexin, of course, is the advantage is that it could be used even in the first 3 to 6 months of life, where cotrimoxazole and nitrofurantoin are not preferred. And it is a very simple drug with very minimal side effects. Cotrimoxazole and nitrofurantoin are also used beyond 6 months of age, but they must be avoided in G6PD deficiency, and nitrofurantoin can cause mild adverse effects like nausea and vomiting. What is a recurrent episode of UTI? Now, the ISBN guidelines recommend the second episode of UTI itself to be treated as a recurrent UTI. Of course, the other guidelines differ slightly, and I'll come to that in a bit. Who is at risk? So those with structural abnormalities, which is mostly seen in infants. This could be anatomical issues like a vesico-ureteric reflux, obstructive uropathy, or a neurogenic bladder. And in toddlers, those with functional issues, usually in the age of the toilet training or between 3 to 5 years of age, and sometimes beyond. Those are associated with bowel bladder dysfunction. Evaluation of the first episode of UTI. So the ISBN guidelines of 2011 recommend that all children with UTI must be evaluated. This is a little different in the other guidelines, and I'll just mention that briefly. So why do the ISBN guidelines recommend such an aggressive evaluation? This is because we still continue to see a lot of children who come with recurrent UTIs in the past, which have been undiagnosed, treated with antibiotics, who come in CKD with scarring, with probably high-grade reflux. We see a lot of children in whom, despite antenatal scans or due to the lack of antenatal scans, have missed obstructive lesions like PUJ obstruction, posterior urethral valves and come to us only when they are in CKD. So this is not an evidence-based guideline, but it is a consensus-based guidelines, because in our situation, we still see children who come with a severe sequelae of missed urinary tract infections. So every child with UTI below the age of 1 year needs the complete evaluation with an ultrasound, MCU, and a Dmsa scan. A child between the age of 1 to 5 years requires an ultrasound and a Dmsa scan, and if the Dmsa or the ultrasound ultrasound are abnormal, then an MCU needs to be performed. In a child more than 5 years of age, ultrasound needs to be done, and if the ultrasound is abnormal, then an MCU or Dmsa is recommended. Most other guidelines do not recommend such an aggressive screening strategy. This is probably because the yield of the diagnosis of UTI is much higher in these countries. The AAP guidelines recommend only an ultrasound for all children with UTI less than 2 years of age. And MCU and Dmsa are recommended only when there is an atypical UTI or a recurrent UTI. The NICE guidelines bring it further down to only 6 months of age. So anybody with a UTI less than 6 months of age requires an ultrasound, and above 6 months, it is only if there is a recurrent or a atypical UTI. What is an atypical UTI? Atypical UTI is when there are systemic features of UTI, or it is a non-E. coli UTI, or if there is an abnormal creatinine that is associated with the UTI. So unless there are any of these scenarios, further evaluation is not recommended. Recurrent UTI, like we saw, the ISPN guidelines says the second UTI is to be considered as recurrent UTI, whereas the AAP guidelines mention that the second episode of pyelonephritis or the third episode of cystitis, which sometimes may be very difficult to distinguish clinically, are considered as recurrent UTIs. So for all practical purposes, we would follow the ISPN recommendations, because this is, though it is not evidence-based, is fitting what we see in our scenario. Ultrasound could be done during the episode of UTI or after the treatment of UTI. It is recommended to be done during the episode of UTI in a young infant who is sick, who is admitted to the hospital, who has a risk of having an obstruction, or who has an abnormal creatinine, or maybe having an antenatal scan that is abnormal. So in all these situations, it is required to be done during. In all other scenarios, it could be done after the treatment of UTI. A VCUG should be done after 2 to 3 weeks of UTI treatment. The gap of 2 to 3 weeks is because we must ensure that the UTI has been treated properly before we do an invasive procedure. Also, sometimes during the episode of acute UTI, there could be a transient reflux. Of course, it is unlikely to be such a high grade 4-5 reflux, but transient reflux of grade 1 to 2 may be seen during a acute UTI itself, and that may be labeled as a vesico-ureteric reflux. So to avoid these 2 points, we need to wait for 2 to 3 weeks before avoiding cysto-urethrogram. A Dmsa is generally recommended 2 to 3 months after the treatment of a UTI. This is because on a Dmsa, we see the area of a scar as an area of reduced uptake. This may be even seen in an acute pyelonephritis, where the area of pyelonephritis does not take up the tracer well. So it may be confused for a scar. So to find out whether it is a scar, we need to wait for a while before the UTI has been treated and settled, and then do it. You can see in this picture that the arrows are pointing towards scar, which are typically in the bipolar regions, that is in the upper and lower pole. And in the middle, this arrow is showing there is a wedge-shaped defect, which is also very typical of a scar. So whenever we diagnose a UTI, we need to know whether there is an evidence of a parenchymal involvement or a recurrent UTI. If so, they need to be evaluated further for BUR and other obstructive uropathies. Any risk factor for anatomical defects, they also need to be evaluated further, and a thorough assessment for a bowel bladder dysfunction. Usually, bowel bladder dysfunction can be treated with proper toilet training and treatment of constipation, but sometimes they may need other therapy as well. The evaluation of bowel bladder dysfunction should be done in every child, especially in the toilet training age group, and this is more commonly seen in girls than in boys. So the common signs are urgency, frequency, holding maneuvers, daytime incontinence, and sometimes enuresis. Of course, if you look at the ICCS guidelines, they will mention that all these symptomatology can be only defined after the age of 5 years. But you must ask this in every child who comes with UTI, especially beyond the age of 2 to 3 years, because some of these may be there during that age and may persist beyond that. And especially if it's associated with a UTI, it may need to be addressed. Constipation is another important risk factor that is associated with the features of the bowel bladder dysfunction. So the hard stool that is there in the colon not only irritates the bladder, but also may prevent complete bladder emptying, predisposing the child to developing a UTI. We use a voiding diary where the time at which the child goes to bed, whether there is bed petting, whether there are daytime symptoms, fluid intake and output are documented. And also the Bristol stool chart, which is used to assess the type of stool. So 4 and 5 are the normal type. And if you have anything between 1 and 3, then there is constipation. Sometimes constipation may be alternating with encopresis. So that also needs to be asked. Again, we have already discussed this, but to quickly mention, there may be features of phimosis, labial adhesions or synechiae, features of a midline defect in the form of a tuft of hair or sacral sinus, which need to be looked at on a thoroughly on a clinical examination. The management of bowel bladder dysfunction consists of keeping a voiding diary, because this helps us to know whether there is improvement or worsening of symptoms, or and also acts as an impetus for the patient themselves to see how the symptoms are improving over time. Timed voiding, where it is recommended that every 2 to 3 hours the child is asked to void. Double voiding, where the child after voiding counts to 10 and again tries to void so as to ensure complete emptying of the bladder. The posture during voiding is very important, and since most people nowadays use the Western toilet, especially for children, where their legs will not be on the floor, resting on the floor, they are sort of dangling. Most of the time, the children are trying to balance themselves on the toilet, and this may lead to them constricting their sphincters, and this results in inadequate or incomplete voiding, resulting in a risk factor for UTI. So giving them a simple solution like a toilet seat, or probably using a stool for their legs to be comfortably rested on, will help to relax the pelvic muscles and to void completely. Adequate fluid intake and also high fiber diet are the dietary recommendations that should be given for the management of or prevention of UTI. And avoiding constipation, short duration of stool softener could be given for a short period of time, but it must be kept in mind to have adequate fluid intake, high fiber diet, and making it a habit to pass stool at the same time every day so that it becomes a routine. In severe cases, pharmacotherapy and biofeedback may be required, but this would require the consultation of a pediatric urologist or nephrologist. As in most cases, even with UTI, prevention is better than cure. So plenty of fluids, frequent time voiding, avoiding constipation, and perineal hygiene are important factors here. Again, coming back to some of the questions, is there a role for circumcision? So circumcision could be useful in a select high-risk cases, but it's not recommended routinely, because the numbers needed to prevent a UTI, the numbers needed to be circumcised to prevent one UTI are extremely high. And it is not a simple procedure, especially in a young infant. It requires a general anesthesia to be given, so it is not recommended as a routine, but in certain select high cases like those with obstructive uropathy, recurrent UTIs, high risk of renal dysfunction, it may be used. Many patients ask this question. We know that most of our patients consult Google before they consult a doctor, and they may say, I've seen on Google that cranberry juice helps in preventing UTI, and cranberry juice is now available in the market, so should I give it? How often? So cranberry juice, there is no evidence as such, even on meta-analysis, to say that there is a reduction in the risk of UTI. So they can have it as a juice, but not as a prophylactic. in a child with a previous UTI, should urine be screened periodically? This is also something that we see commonly. Either the parents do it themselves, that they are scared, and every time, every 2 to 3 weeks, they just get a urine done. So we know that the diagnosis of UTI is in the presence of symptoms. So in the absence of symptoms, there is no indication to screen the urine routinely. What we always suggest to our patients is, whenever there is fever, especially fever without a focus, give only paracetamol and get the child to a hospital to get a urine routine and culture tested properly. If it's an older child and you're asking for a clean cat sample, explain the procedure of the clean cat sample thoroughly to the patient and make sure they have understood it. If it is a young child who cannot have a clean cat sample collected, then we ask them to report to the hospital whenever there is a fever without focus for more than 24 hours. And we make sure that we collect a catheter sample using aseptic precautions to make a diagnosis of UTI. Finally, when should you consider referral to a pediatric nephrologist or urologist? Whenever there is a UTI with an underlying urological abnormality, renal dysfunction, scarring or risk of chronic kidney disease, and severe bowel bladder dysfunction requiring urotherapy. Thank you for a patient hearing.
Yeah, thank you, Dr. Nivedita. It was a wonderful presentation on the management of UTI and prophylaxis. And your 3 S's, that is single colony count, single organism, and symptoms. These are 3 S. This is very important. And your clear-cut presentation on evaluation and management of bladder bowel dysfunction in the management UTIs was wonderful, madam. And the clinical response should guide the therapy. That is also very important point, take-home message, madam. And subject to correction, I want to ask one question, madam. This in the parenteral dose of co-amoxiclav. In your slide, it was 30 to 35 milligrams. I remember it is around 50 to 75 milligrams.
So about 30 to 40 is what is recommended by most guidelines. I would ask the other people to correct me if I'm wrong. This is what we routinely use in clinical practice also, 30 to 40. The higher doses are recommended, I think, only for certain infections like meningitis or some infections like that. But for UTI, it is the same 30 to 40 milligram per kg.
Yeah. Okay. Thank you, madam. Thank you. Now over to Dr. Mehrul Shah, sir, for his talk on the imaging studies in the URTI. Sir, Dr. Mehrul Shah?
Yes, yes.
Sir.
Am I audible? And
yes, sir. Yes, sir.
Yeah. Okay. So thank you, Dr. Lakshman Garu. And once again, I think I'm fortunate to have been buffered by great people. Himesh, the first pediatric nephrologist in Meghalaya, Nivedita, the first DM pediatric nephrologist, and after me, though we say that Pankaj Deshpande is there in the lower down batting order, but as we know that nowadays the lower order players have been true all-rounders, and Pankaj is one of them. He's the first pediatric nephrologist in Navi Bombay. I think my job has been made a little easy both by Himesh and Nivedita, so there may be some repetition of what has already been discussed, and I'll try to skip some slides over here. I would just like to add one more point over here that Pankaj is the captain, and I think the vice captain over here is Dr. RSV Sri Krishna, because he has added a lot of toppings to the overall flair of the symposium over here. So thank you, RSV. I think the question is, we have diagnosed and treated a child with urinary tract infection. Is the treatment of UTI stopped over here after the antibiotic therapy? The child has recovered, the family is happy, the child is back to his or her baseline. So do we stop the treatment of UTI with antibiotic therapy? And the answer is no. At the end of antibiotic therapy, or while we are discussing the management of UTI with the family, we need to ask 2 questions. Why did this child get UTI? And second, why should we worry about this UTI? I think there are many published studies which have demonstrated that pyelonephritis may be the first indication of an underlying pathological condition, such as anatomical abnormalities in 10 to 36% of children, especially below 3 years of age, presence of vesico-ureteric reflux, which is detected in up to 50% of children under 2 years of age with first episode of febrile UTI, dysfunctional voiding syndrome, or more importantly, dysfunctional elimination syndrome, which is one of the common factor for recurrent UTIs in older children, and hypercalciuria or renal stone disease. So these are the important predisposing factors for a child to get one or several episodes of UTI. So what are the radiological investigations that can be performed in a child with UTI? First, ultrasonography, basically to identify structural abnormalities. Second, micturating or voiding cystourethropy, MCUG in our country, Western countries, it's called as VCUG, mainly to detect and grade severity of VUR, look for bladder abnormality, and also to rule out posterior urethral valves in boys. Third, a direct radionuclide cystography, which we'll come to in next few slides. This is mainly useful in follow-up for children who have got VUR. A Dmsa Renal Scan to identify the split renal function and to look for scars. And finally, MR urography or occasionally CT urography for further delineation of complex anatomical abnormalities such as duplex system, obstructed megaureter, or an ectopic kidney with pelvic-ureteric junction obstruction. So when should we do ultrasound? And why? So these are some of the situations which we can pick up by doing a screening ultrasound of the kidney ureters and bladder to look for hydronephrosis, which could be because of PU junction obstruction, a unilateral multicystic dysplastic kidney or hydronephrosis, an obstructed megaureter. It could be a kidney size discrepancy. One kidney is smaller as compared to the other, and sometimes uretroceles can be picked up on an ultrasound. Usually the ultrasound, as Nivedita has mentioned, should be done within the first week of the diagnosis of UTI and not delayed. Some of these children may need more aggressive therapy. Question is, can a normal renal ultrasound rule out VUR? Yes, we can pick up a number of anatomical abnormalities, but can we say that VUR is absent if the renal ultrasound is normal? And the answer is no. A normal renal ultrasound will not rule out vesico-ureteric reflux because VUR is an intermittent phenomena, and hence ureteric dilatation may not always be apparent when we are doing the sonography. This has been demonstrated by the study published about 30 years ago by Blaine et al., who found that 74% of kidneys with VUR, 74%, that means 3 out of 4 children with VUR had normal ultrasound without any evidence of ureteric or renal pelvis dilatation. In our own unpublished analysis in 2010, we found that 30% of children with high-grade VUR, that is grade 4 and grade 5 VUR, had either normal ultrasound or very mild renal pelvis dilatation. And hence, a normal renal ultrasound should not say that there is no vesico-ureteric reflux. The next investigation modality is micturating cystourethropy. Why should we do it and when should we do it? I think MCUG, the radio contrast micturating cystourethropy, has been the traditional method of evaluating VUR. On the left-hand upper screen is the normal MCUG, which shows a smooth wall bladder with normal urethra and no vesico-ureteric reflux. Besides looking for VUR, it also tells us the severity of VUR, and this has been graded as per the International Society for Reflux System, IRS. Grade 1 and 2 is non-dilated reflux, where the ureter is not dilated. Grade 3, 4, and 5 is reflux in dilated system with progressively increasing severity of dilatation, tortuosity, and flattening of the minor cholysis. It also helps us in detecting anatomical details, sometimes a diverticulum or a duplex system, which can be missed on an ultrasound. And more importantly, it helps us to rule out posterior urethral valves in boys. So these are the advantages of doing micturating cystourethropy. However, it has its own limitations and disadvantages. One, we know it is an invasive procedure. It definitely causes discomfort to the child. Certainly, the parents are also quite distressed looking at the procedure. There is a risk of radiation exposure. And more importantly, we should be aware that MCUG can miss VUR in about 10 to 15% of cases due to both intermittent nature of VUR and also because of intermittent exposure. We do not press on the pedal of fluoroscope continuously to minimize radiation exposure. And hence, there is a possibility of missing vesico-ureteric reflux in about 10 to 15% children. When should MCUG be performed? I think this has been briefly covered by Nivedita in the previous talk. Yes, traditionally, we used to perform MCUG after 4 to 6 weeks of UTI. And why was that? The main concern of doing MCUG early at that point was we may overestimate VUR when it is done early because of infection, release of endotoxins, and edema at the VU junction. There may be transient reflux. So we may be overdiagnosing reflux, especially low-grade reflux, and we may also overestimate the severity of reflux. So for both these reasons, it was thought that the MCUG should be performed 4 to 6 weeks after resolution of the febrile episode of UTI. However, what has been found is most of this data was based on animal studies and it has not been proved in humans. There have been few reports over the last 20 years to show that it is better to do MCUG early rather than late, early meaning within the first 7 days after the diagnosis as compared to 4 to 6 weeks after. And I'm just going to present one of the studies, which is a recent systematic review published in Archives of Diseases of Childhood. This was a pool of 9 studies, including 1,700 children. Data of children who had VCUG in the first 8 days was compared with those who had VCUG or MCUG after 8 days of the onset of UTI. And the results showed that the pooled prevalence of vesico-ureteric reflux was not significantly different between early and the late groups. Their conclusion, early VCUG within 8 days after onset of UTI does not affect the prevalence or severity of VUR. This study was published just recently. So why should we do MCUG early? If not at 4 to 6 weeks, why should we do it early? Early meaning within the first 5 to 7 days of diagnosis of UTI. One, it is convenient. It reduces parental anxiety. Waiting for 4 to 6 weeks to know whether there is reflux or there is no reflux definitely prolongs the parental anxiety. Third, it eliminates the need for antibiotic prophylaxis, especially in small children. We may have to put them on chemoprophylaxis until the MCUG is done. And fourth, more importantly, not just in our country, but even in Western countries, it has been demonstrated that there is a possibility of no follow-up after the child is better. In this study by McDonald et al. In 2000, VCG was not performed in 48% of children when it was scheduled more than 7 days of UTI. And in another study, 52% of children and families were lost to follow-up after resolution of UTI. And hence, it is suggested to get the MCG done early once the infection is under control. The child is on antimicrobial therapy, which is usually between 5 to 10 days of the diagnosis of UTI. The third investigation modality is DRCG. The full form is direct radionuclide cystography. Why should we do it and when should we do it? This is an alternative method of detecting vesico-ureteric reflux. Usually, it involves direct suprapubic bladder injection of radiotracer in a distended bladder. And while the child is voiding, the gamma camera continuously observes the bladder and the kidney area to look for reflux. And this is what it is demonstrated over here. This is the only time we ask the child to hold on to the urine. With the distended bladder, we inject the radiotracer in 2 ml of normal saline suprapubically. And as the child starts voiding, the gamma camera is turned on and we observe. Here we can see the radiotracer is going back up into the left system and it is going up to the system and it is equivalent of grade 2 reflux. The advantages of DRCG are that it has a higher sensitivity due to continuous imaging as compared to intermittent imaging with radio contrast MCUG. Sensitivity is not 100%, but it is definitely 10% higher as compared to MCUG. There is no effect of overlying bowel gas or fecal matter, which sometimes can make us miss a low-grade reflux. Certainly, there is a lower gonadal radiation as compared to radio contrast MCUG. and it is less painful and traumatic as compared to MCUG. We are not inserting the catheter, but we are doing a suprapubic bladder injection using a 23 or a 24 gauge needle, and it's much more patient-friendly as compared to MCUG. However, like any diagnostic test, it has its disadvantages. One, it can be performed only in children who are toilet trained because you want the child to hold on to the urine. If we are planning to perform this in children less than 3 years, we would need to catheterize the bladder. And instead of injecting the radio contrast, we are going to inject the radio nuclear medicine. And more importantly, it cannot detect anatomical abnormalities like diverticulae, PUV, or a duplex system, and even low-grade reflux because of blurred images can be missed by DRCG. So what are the indications? We have a test which is superior to MCUG, has its limitations. So when should we consider DRCG in the evaluation of a child with UTI? One, I think the most helpful indication is going to be in the follow-up study of a child who has already been diagnosed to have VUR, to know whether the VUR is still persisting or has it resolved. This becomes a very helpful radiological study. Second, it is helpful in girls because we do not find urethral abnormality like we find in boys. And third, when we are screening for siblings of index patients with VUR, DRCG can be an option in place of MCUG. Certainly, it should not be used in boys as the first study because we want to evaluate the urethra as well as the bladder for its abnormal anatomy. The fourth investigation is MRU, magnetic resonance urography. Why should we do it and when should we do it? This is a newer technique in pediatric urinary tract imaging. It has its advantages because it gives detailed anatomical details, functional information of uptake, excretion, drainage when dynamic contrast enhanced technique is used. It can also help differentiate between dysplasia and acquired renal scars, which a Dmsa scan cannot. And more importantly, there is no ionizing radiation when we are doing MRU. However, the flip side is it is a costly test. It often needs sedation in young children, and we have to be careful when using gadolinium as the contrast in children who have got moderate to severe chronic kidney disease. There are limited indications of using MRU. One of them is when evaluating a child with obstructed megaureter, children with duplex system, or children who have got ectopic kidney with pelvic-ureteric junction obstruction. So that is in brief about MRU. Certainly, there are some pediatric surgeons and urologists who would like to do CT urography because of better anatomical delineation as compared to MRU. But again, we need to ensure the renal parameters are normal, and then only we should proceed with CT urography. And the final test which is required is a Dmsa scan. Why should we do it and when should we do it? So what is Dmsa scan? It is dimercaptosuccinic acid renal scan. It molecule DMSA binds to the functioning cortical tissue cells. It binds to the sulfhydryl molecules present on the apical membrane of the proximal convoluted tubular cells, and hence it gives you information about the healthy tissue. If there are non-healthy tissues such as a scar or an inflammatory area, it will not pick up the molecule and it will be labeled as a cold area. The limitation of a Dmsa scan is that it cannot differentiate between an inflammation, a scar, or a cyst. All of them are going to appear as a cold area. Friends, just a brief distinction between Dmsa scan and a Dtp scan for the young postgraduates. Dmsa scan is a static scan which tells us about the cortical function. Are there any cold areas or there are no cold areas? Because less than 10% is excreted into the urine. So it is bound to the cortical tissue. In comparison, a Dtp renal scan is a dynamic scan, and its main evaluation is for the function of each kidney and to see if there's any obstruction at the pelvic-ureteric junction. So this is a static scan for function of the cortex, whereas a Dtp scan is more to evaluate an obstruction. Here we can see that the left kidney on the left side of my screen has picked up the tracer less as compared to the right kidney over here. And at the end of the imaging, 20 minutes, the right kidney, there is no tracer left behind, whereas the left kidney, there is significant amount of tracer left behind, suggesting a PU junction obstruction with mildly reduced renal function. So we perform Dmsa renal scan for two indications. One, to evaluate the split renal function, and second, to look for renal scars. So when should we do Dmsa scan? As we know, an acute Dmsa scan is going to show cold areas. In the first 6 months, it will be difficult to differentiate a cold area from inflammation or due to scars. There is continuing resolution of the pyelonephritic cold areas, and a 12-month interval is more reliable to look for permanent scars rather than doing it early. So in fact, most centers would suggest doing a Dmsa scan after 6 months and not before 6 months if we are trying to look for a scar. Within 6 months, a cold area, maybe because of the residual pyelonephritis inflammation, and there is a 50 to 60% chance that this cold area is going to resolve over a course of 12 months. So we should get a Dmsa scan preferably at 6 to 12 months after the episode of a pyelonephritis, because the Dmsa scan is not immediately going to change our management, but it is going to help us in the long-term follow-up of these children. So why should we worry about VUR? Again, this has been briefly discussed by Nivedita, but the 1960s to 1970s was the watershed decade when active therapy and interventions in urinary tract infection was incorporated. 10 years later, George Bailey changed the word chronic pyelonephritis to reflux nephropathy. 1980s to 2000, we came to realize that reflux nephropathy accounted for 10 to 17% of ESRD in children worldwide. That's a significant proportion of children reaching end-stage renal disease because of reflux nephropathy. And then in the later part of last century, we realized the concept of congenital scarring, mainly because of prospective evaluation of children with antenatal renal anomalies, getting their MCUGs done early and getting a Dmsa scan done before the first episode of UTI. That's when the concept of congenital scarring or dysplasia was brought into understanding. So why should we worry about VUR? Friends, because VUR not only results in recurrent UTIs and has its own morbidity, as was discussed by Himesh, it can also contribute to renal scars. And the renal scars are the ones which are going to lead to morbidity over long term. It has been found that it can cause hypertension in children up to 30% of cases, proteinuria, chronic kidney disease, and end-stage renal disease requiring renal transplantation. And certainly in young girls, it can lead to pregnancy complications during their childbearing age group. So for all these reasons, we should be alert about VUR, reflux nephropathy, and the risk of hypertension, proteinuria, chronic kidney disease, and pregnancy complications in young women. There are two aspects of renal scars. Until 1995, we used to think that it's only pyelonephritis which was causing renal scars. But from 1995 onwards, the concept of congenital scarring or dysplasia has been brought into attention, and it's a combination of both of them which gives rise to renal scars. So who is at risk for renal scars? My last few slides. Infants who are less than 2 years of age due to presence of compound papillae at the poles of the kidney that permit intrarenal reflux are at the highest risk for developing renal scars. In this study by the International Reflux Study Group, new scars were found in almost 25% of children less than 2 years of age, as compared to only about 5% in children less than 5 years of age. And hence this cutoff of 2 years where we are more aggressive in evaluating for reflux. Second group of children who have got moderate to high-grade reflux are at a higher risk of developing renal scars, both because of genetic predisposition or dysplasia and also because of recurrent febrile urinary tract infections. The third group of children who are going to be at risk for renal scars are those in whom there is a delay in initiation of therapy. Although this is an old study, but I think it still holds true. Children who have been treated within 72 hours of onset of fever have a 4% risk of developing renal scars, as compared to children who initiated therapy more than 72 hours after onset of fever have a 4-fold higher risk of developing renal scars. And hence, we start the antimicrobial therapy with the suspicion of UTI after sending the urine culture, and we do not wait for the urine culture to confirm UTI. And the fourth group of children who are going to be at risk for renal scars are obviously those who have got recurrent urinary tract infections. This study showed that children who have got no or one episode of UTI have a lower risk of renal scars as compared to those who have got 4 or more have almost a 50% risk of developing renal scars. So these are some of the risk factors for children developing renal scars. And why should we worry about renal scars? We have briefly gone through the details earlier, but I would like to share this very important long-term study, probably one of the very few long-term studies in pediatric nephrology by Jean Smelly et al., who has been credited of initiating the discussion of UTI, VUR, and reflux nephropathy. She's a pediatrician. She was a pediatrician from Great Britain, and she did a lot of pioneering work on UTIs and reflux. I'm not going to go into the details of the entire study, but have highlighted that 226 children were followed from up to 10 to 44 years after their diagnosis of UTI and VUR. And what they found was 37% of this 226 adults had renal scars. No new scars developed after puberty. That was one observation. Second, 10% of children had developed hypertension, those who had VUR. That is 23 out of 226. This hypertension was predominantly noted in those who had renal scarring. That is 20 out of 23 with renal scars had hypertension, as compared to those who did not have renal scars had a low percentage of developing hypertension. Only 2% of children who did not have scars developed hypertension, as compared to 25% who had renal scars developed hypertension. And finally, 16 out of 17 children with renal scars ended up having chronic kidney disease, as compared to only 1 without scars. 3 adults with renal scars lost their lives because of end-stage renal disease. So their observation was that VUR, but no scars, no serious complications, but VUR with scars, there's a risk of hypertension and chronic kidney disease. And hence, we should not ignore VUR and reflux nephropathy. How to evaluate a child with UTI? I'm going to skip this because this has been covered by Nivedita. Just to be aware that any guidelines which are published should be looked at the other side as well. Guidelines would help us take care of a child, but we should be aware about the limitations of a guideline as well. These are some of the guideline limitations. The first episode of UTI may not always be the first episode. It could be the second or the third episode. Patient compliance, long distance travel are very common issues in our developing countries. We are aware that normal ultrasound does not rule out VUR. And also, normal ultrasound and negative Dmsa renal scan does not rule out VUR, PUV, bladder diverticuli, uretroceles, and other anatomic abnormalities. Dmsa renal scan is still an expensive diagnostic test and not freely available in all the cities of our country. Finally, friends, to complete this discussion, just one line about dysfunctional voiding syndrome, very elaborately discussed by Nivedita. But while there is a lot of confusion, debate, and discussion about what modality should we use to evaluate a child with UTI, should it be ultrasound, should it be MCUG, should it be a DRCG, should it be an MRU, I think Stephen Koff in mid-80s, one of the pioneers in pediatric urology, brought out a nice statement. Instead of arguing about what modality should we be looking at, why not we pay attention to the voiding and stooling history, which often contributes to a risk for recurrent urinary tract infections. This picture on the left shows that when the detrusor contracts, it is a smooth muscle not in our control. We relax the external sphincter, which is a striated muscle and under our control, which we learn to relax and contract by 2 to 3 years of age. However, in children who have got voiding dysfunction, when the bladder is contracting, the detrusor is contracting, instead of relaxing the external sphincter and opening the channel, we contract it and we try to close it. And hence we generate a high pressure. We end up having residual urine and risk of urine infections. So to summarize, friends, every child under 2 years of age with first febrile UTI and older children with recurrent UTIs or abnormal ultrasound should have an MCUG and Dmsa scan done. MCUG should be done during the course of therapy and should not be delayed. A Dmsa renal scan should be done 6 months to preferably 12 months after febrile UTI. DRCT can be performed in toilet-trained children to follow up on confirmed VUR or post-surgical evaluation. Magnetic resonance urography has a limited role in defining complex anatomical abnormalities. And finally, reflux nephropathy or renal scars are associated with hypertension, proteinuria, chronic kidney disease, and pregnancy complications. These children need long-term monitoring. Thank you so much, friends.
Yeah, thank you, Dr. Meherul Shah. It was a comprehensive talk on the radio imaging and UTIs. So what we learned today is early MCUG within 8 days. Yes, sir. Am I correct, sir?
Yes, Dr. Lakshman Raghu. Yes.
Within 8 days. Who is on antibiotic? We can send him directly MCUG, no, sir?
Absolutely. So I think till early 2000, we used to wait for 4 to 6 weeks. But once the child is better, as Nivedita mentioned, once the fever has come under control in about 48, 72 hours, we get a repeat complete urine examination on day 3, day 4, and show a resolution or reduction in the pyuria. We don't need to repeat a urine culture. We can straight away go ahead and get an MCUG on day 5 to day 7 of the antimicrobial therapy. That's true.
Yeah.
Yes.
Thank you, sir. It was a wonderful. Just we learned today itself MCUG within 8 days. Thank you, sir. And also it was wonderful presentation, like DTP, Dmsa Scan, the differences. Yes, sir. Thank you. It was a wonderful presentation, sir. And any questions, please put it on chat box. And next we will go to our captain, Dr. Pankaj Deshpande, who will be speaking on common errors in UTI and management and diagnosis. Over to Dr. Pankaj Deshpande.
Thank you. Can you hear me?
Yes, sir.
Yeah. And you can see the screen?
Yes, sir. Yes, sir.
Has it become a slideshow properly?
Yes, Pankaj, yes.
Yes,
Yeah.
okay.
Yes.
Thank you for inviting me to share some of my thoughts. As Mehul said, that I'm going to be talking about googlies that we face in the clinic. Now, Mehul is kind of my guru. Not necessarily that I agree with everything that he says in terms of the subject, but that's a different part altogether. So what is this googly that we are talking about? The most difficult aspect for any human being is to unlearn what he has learned. So we all know what is a urine infection. So if you go back to your MBBS days, when I went for an exam, I didn't need to know what I knew. I also needed to know what I didn't know. Now, Mehul never faced that problem because he knew everything. So that was a different matter altogether. But similarly, even in a urine infection, we need to know what is not a urine infection, because otherwise we'll keep chasing our own tails without actually benefiting either the patient or ourselves as doctors. And as I always say, our patients teach us a lot more than what the textbooks and guidelines teach. So let's start directly with the children who present to the clinics. Now, these are all true cases that come to the clinic. This is a 3-year-old boy who presents with fever for 1 or 2 days. There's no focus that you can find on examination. Fever is mild, and the mother and brother have a cold and cough. Very often this history is not taken anyway. So this child, because he has a fever without focus, you ask for a urine test. And as you can see, it shows a specific gravity of 1025, a bit of protein, some blood, and pus cells 12 to 15, RBCs 1 to 3. Now the parents come back in the evening with the child and get this report, by which time he has developed a cough and runny nose. So I'm sorry, I can't make this interactive because it's not a live presentation that I'm doing. But the question that I often ask the audience is, now, do we treat this as a urine infection? So the simple answer, if you have heard all the previous talks, which were very lucid, is no. Because significant pyuria, which means that presence of more than 5 pus cells per high power field in a centrifuged urine sample, or more than 10 per cubic millimeter in an uncentrifuged urine sample, can be present due to many reasons. So pus cells is not equal to urine infections. They are not pathognomonic of urine infections. Any inflammation anywhere in the body can cause pyuria. And as Himesh rightly said, any fever can give rise to pus cells in the urine. So that does not mean this child has a urine infection. Dehydration can give rise to pus cells in the urine. Any form of nephritis, whether you talk of glomerulonephritis, interstitial nephritis, calculi, hypercalciuria, these can all be reasons of pyuria in the urine. And the important lesson that we should learn, which you need to be brave about, is in a child having fever without focus. If you have sent a urine test, but then you identify a focus later, you need to be brave enough to call that as the reason for fever and label it as not being a urine infection. Because otherwise we'll keep on treating these children as having urine infections. So this second child is a 7-year-old girl who has abdominal pain, no other symptoms, and the girl was asked to do urine tests. Now this girl has a urine routine, everything else was bang normal, including the pus cells, which were 1 to 2, and a urine culture showed more than 100,000 organisms per ml, which was E. coli. So is this a urine infection? Now people talked about asymptomatic bacteriuria, but I would go one step before that, because what we do, the most important aspect of diagnosing a urine infection is the urine test that you do. And we hardly spend any time in explaining how to collect urine to the patient. So as these 5 things that are given there, I usually say, unless these 5 things are present, please do not show me any urine report, because it does not make any sense. So you will do a urine test when you suspect a urine infection. When do you suspect it? In an infant, if there is fever without focus, or in an older child, if there are urinary symptoms with or without fever. It has to be a midstream sample in an older child, a clean catch urine in an infant. After cleaning the genital area with normal soap and water, it has to reach the lab and be plated within 1 hour. There should be no vulval redness in girls, which is a very important thing that is overlooked. Remember, a urine sample left in room temperature for more than 1 hour will show contaminant growth. That is neither a symptomatic bacteriuria nor a urine infection. It is just poor collection of a urine sample. This girl, if you went into the history and spent a few minutes, you would have realized that that's what the father did. He collected urine in the morning at 7 o'clock. The lab opens at 9 o'clock. He put the sample in his pocket and brought it to the lab and gave it at 9 o'clock. And that is the reason why you're seeing the culture being positive. The second important point to note here is that the child did not have symptoms that suggested a urine infection, and yet we keep on asking for urine tests and get ourselves into a muddle. The next child is this is a very common scenario, and I'm sorry we don't have enough time to talk in detail about this third particular patient, because we see this very often. This is a 6-year-old girl who presents with dysuria. There are no complaints of fever, and this girl has had similar episodes frequently in the past. Now, when I say frequently, I'll come to that in a minute. So you ask for a urine test in this girl. It shows a specific gravity of 1030. There is trace protein, 15 to 18 pus cells, 1 to 2 RBCs, and 4 to 8 epithelial cells. Now, if I tell you the history that this girl has had these episodes, now you name it, and I can tell you different examples, 4 months, 6 months, 1 year, where the child keeps on getting these symptoms, has this urine report, is given antibiotics, feels better in a few days, and then comes back again in a few weeks. The urine tests that have been done numerous times have shown normal pus cells, 10 to 15 pus cells. Cultures have shown 10,000 organisms, 100 organisms, 1,000 organisms, you name it, and it's there. So the question is, what is this? Is this a urine infection? And these children, unfortunately, also get an MCU done, which is very often normal. And God forbid, if it turns out to be abnormal, then you've had it. So what else are you going to ask in these girls? There are 2 differentials, which I call as UTI mimics, which you need to be aware of. The first one is, in your history, you're not only going to ask about dysuria, you're going to ask, when is the pain present? And you will often find that the pain is not only present during voiding. Yes, dysuria is present, but the pain is present throughout the day. So in fact, some of these children wake up at night crying with pain, and that's not when they are passing urine. They just wake up because it's severely burning or paining. They have severe itching locally, which is present. One of the very important clues that you find is that the girl goes to pass urine and splashes water on that area after she finishes voiding. Why does she do it? because she's got burning and itching in that area. So what does this child have? This child has vulval redness, and if you have not examined by separating the labia, you're never going to pick this up. So why do your antibiotics work? When we give antibiotics, do you think it really works in this girl? No. The child goes home, the grandmother is putting oil in that area, and therefore the child feels better, which lasts for a few weeks, and then she comes back again with the same symptoms. So what is the treatment? The treatment is you treat with emollient creams, moisturizing creams. There are two aggravating factors for this vulval redness, which you see in these girls. One, very surprisingly, is repeated washing of that area. So if you have dry skin on your hand, you do not go and wash that area, you put moisturizer. That's exactly what happens here. The more they wash, any mother who comes to know that the child has had a urine infection, she goes into an aggressive mode, and there is repeated washing which occurs, which gives rise to dry skin and these kind of symptoms. And secondly, the use of antifungal creams. These children do not have fungal infection. This is the redness which is present because of antifungal creams or repeated washing. So unless this is treated, you collect a urine sample, you'll get all sorts of reports, including a positive urine culture. So these children never have a urine infection, and you really need to examine them to find out whether it is present. The second differential which is present for this particular girl is called as detrusor instability or an irritable bladder syndrome. I won't go into the details of that because it will take up a lot of time. But the point about daytime wetting and the number of times the child is voiding, this is not volunteered because the wetting is very minimal. It's a few drops of urine that the child passes in the underwear 3 or 4 times a day, and therefore the parents do not consider that as significant. So that's the other differential for this girl who presents with this kind of a history. Especially antibiotics being given for 6 months, 12 months, this child never gets relief. So the next girl is a 4-year-old girl who presents with abdominal pain, which is present mild on and off. There's no fever or dysuria. You examine the child, everything is normal. You get a urine test done. Again, it shows a specific gravity. I'm deliberately putting the specific gravity of 1030. The reason being, most of these children don't drink enough fluids, and that's why they get all these kinds of symptoms. There's a little bit of protein, some trace blood, 2 to 4 pus cells, and RBCs 1 to 3. Now, this child has an ultrasound done for the abdominal pain. And as you often read the impression that is given by the radiologist at the end, it shows normal shape and size of the kidneys, but a thickened bladder wall suggestive of cystitis. Now, this is often treated as a urine infection. Now, most people will treat this as a urine infection. And I just want to point out again, I would like this to be interactive because I would like to get people's views. But here I have put a picture of an ultrasound showing a bladder. Now, if you can see, this bladder is thick-walled because the thickness of the bladder should be less than 2 millimeters. And as you can see, this is a bladder which is more than 2 millimeters thick, which will get reported as thickened bladder wall. Now, the same bladder in the same child here is a thin-walled bladder. So how does that happen? Bladder wall thickness more than 2 millimeters is on a full bladder that we call as bladder wall thickness. So unless the bladder is completely full, calling it thick-walled is erroneous. And you're going to keep on treating these as cystitis or urinary infection. Remember, diagnosis of urine infection is based on symptoms and urine tests. It's not based on an ultrasound scan. Ultrasound does not give you diagnosis of urine infection. So not only do you need to look at the report of the ultrasound or the impression that is given, you also need to start asking for pre-void and post-void urine volume. Because the bladder capacity, now some people take it as age plus 2 multiplied by 30, some people take it as age plus 30. But if you have got a 6-year-old child, 6 multiplied by 30 is 180 ml. So unless the bladder is close to that volume, reporting a thick-walled bladder is erroneous. So these are not children who have cystitis, so don't call them as urine infections. This next one is a 4-year-old boy who presents with puffiness of the eyes and face for 8 days. There's no past history, no fever or dysuria that the child has. And you do a urine test which shows 4+ protein, 15 to 18 pus cells. Albumin, as expected, is low at 1.8. Cholesterol is elevated at 315. So clearly this child has nephrotic syndrome. But is it nephrotic syndrome with urine infection is our question, because most of these children get antibiotics given because of the pus cells present in the urine. So let's be clear that so-called pus cells in the urine in this case are inflammatory cells. So unless there are symptoms of urine infection, this is not a urine infection, and please don't give antibiotics to these children. If I had changed the history of this child and said that this child presented with cola colored urine, a little bit of puffiness with the blood pressure elevated, and I had shown you 20 to 30 RBCs and 10 to 15 pus cells, you would not have batted an eyelid. You would have called that nephritis. How is nephrotic syndrome different from nephritis? Because the inflammatory process is the same, and therefore you're going to get pus cells in the urine which are not necessarily a urine infection. So unless there are symptoms of urine infection, please don't call this as a urine infection. This next one is a 5-year-old girl who had fever for 2 days, no focus on examination, and a urine test showed turbid urine, 50 to 60 pus cells. Culture was sent, and as has been said by all the speakers, please send a culture before you start antibiotics, because otherwise you're going to get into a mess. And then the child was started on cefixime. I think this has already been covered, but I'm just going to go over it again because it's a very important aspect. So on follow-up, after 48 hours, when the child comes back to you with the culture report, the child is febrile with no symptoms. Urine culture shows significant growth of E. coli, which is resistant to cephalosporins and sensitive to injectable antibiotics. So do you now admit the child for IV antibiotics? The answer is no. If the symptoms resolve, there is no need to change antibiotics, because the urinary concentration of the antibiotic that you're giving is pretty high as compared to in vitro and in vivo concentrations that we measure. So there's no need of admitting this child. The second part of this is the 10 days later, the child is completely well, and you've repeated a urine test, which shows 15 to 20 pus cells and a urine culture of E. coli 10,000 organisms per ml. So are you now going to say that this is incomplete clearance of a urine infection and admit the child for IV antibiotics? I think Dr. Nivedita already covered it. Repeat urine culture is not required in a child with urine infection where symptoms have completely resolved. And I think this is the bottom line. Please do not repeat urine cultures. Repeat urine routine also in an asymptomatic child has no significance, because as I just said, unless you have looked for other reasons for the pyuria, you may get pyuria in the urine. So that may not necessarily tell you that the child has got a urine infection. So the child is now advised to do urine routine every month to look for urine infections. I think Nivedita covered it pretty well. No surveillance samples, because urine infections do not announce and come on the 1st of every month. So the urine test has to be done when the child has symptoms suggestive of a urine infection, and not on a regular date like the 1st or the 5th of every month. It's not a pay. The final case for today, this is a 4-year-old boy who presents with history of fever and dysuria. Urine shows 30 to 40 pus cells. The culture shows 1 lakh organisms per ml of a single species. So he's treated with oral antibiotics for 10 days. The symptoms settle down. The ultrasound shows normal kidneys and bladder. A DMSA is done 2 months later. And I apologize for the quality of the picture, but if you look, the right kidney looks normal. The left kidney, upper pole and lower pole show a reduced uptake. So this is reported as scarring in the left kidney at the upper and lower poles. So my question is, how would you follow up this child? And I'm not interested in the long-term follow-up. The message which I want to give, I think, was already made out by both Dr. Nivedita and Dr. Mehul. When you repeat a Dmsa scan 6 months later for this child, the same nuclear medicine center now reports this as pristine normal kidneys with no scarring. Now remember, scarring is fibrous tissue. It cannot disappear. A DMSA only shows you reduced uptake in that area. Therefore, all that is reported as scarring on a DMSA scan is not scarring. Acute changes in the kidneys can also look as reduced uptake and can get reported as scarring. A DMSA is to be done 6 months after the urine infection has resolved. And most importantly, please remember, we do not do a DMSA scan for every child who's born at birth. It shouldn't be done anyway, but even at 3 months. because you cannot differentiate between dysplastic areas and scarring even when you do a DMSA 6 months or 1 year later. So it is your interpretation of the symptoms which the child presents, the clinical scenario, and your examination which is going to tell you whether it is dysplastic area or scarring. So to finish off, just remember that pus cells in the urine do not equal to urine infection. Urine collection has to be appropriate and has to be explained. Local examination, wetting in a child has to be asked and looked for. Don't get misled by radiology reports, and get the timing of investigations right. Thank you.
Yeah, thank you, Dr. Deshpande. It was a wonderful presentation of 8 different cases which mimic the urinary tract infection, and you clearly emphasized on clinical response should guide the clinic treatment therapy. Thank you very much, sir. And also about DMSA scan, which should be done after 6 months of UTI. Thank you. It was a wonderful presentation, sir.
Thank you.
Thank you. And let us take up any questions in the chat box.
There are no questions.
There are no questions?
Only appreciations.
Oh, right.
Dr. Lakshman, there is one comment. Please read that. Rekha.
Yeah.
There is one comment.
Recording charts. I'm not able to get that.
The comment is, will early DMSA scan be fallacious if inflammation of kidneys leads to reduced tracer uptake? Look like scars. Anyone of you can take up this comment.
I since I was the last batsman, let me take that. So the simple answer is, I think Mehul and Nivedita made it very clear. You can get changes on a DMSA due to acute inflammatory changes, due to scarring, and as I added, dysplastic areas. So when you get changes on the DMSA scan, you can't call it fallacious. It can be one of these 3. Of course, there are other reasons for abnormalities on a DMSA. For example, if you do it in a child who's got an elevated creatinine, you're going to get an abnormal DMSA. So that's not giving you the cause of the raised creatinine. But you need to be aware of these changes. So I don't know what you mean by fallacious. The problem is that if you do it early, you may pick up acute changes which are going to resolve over a period of time. So that's what we are saying, that it should be done 6 months after the UTI has resolved. Mehul, if you want to add in.
No, I think that you covered it quite nicely, I think, and that's true. Means it's not fallacious; it's just a cold area, and we should be waiting for at least 6 months, and I would say even longer, because there have been some studies where they have found that up to 75% of these cold areas may resolve by 1 year. So the question we need to ask is, why are we doing the test? What information is the test going to give us, and what are we going to do with the result of the information? So the DMSA scan, we are basically looking for a scar. Looking at a scar at 3 months, 6 months, or 1 year, because we know that the changes may resolve. It's an expensive test. We might as well wait till 1 year or 6 months at least, and then get the test done. So the only indication for doing an early DMSA scan, Pankaj, if I can add, is if you have a child with a high suspicion of pyelonephritis, the urine pus cells are borderline, say 8 to 10, and the culture report is unremarkable, like it has come negative. You don't know what is the focus of infection. I think that's one of the rare situations where we may do an acute DMSA scan to see for any cold areas. But except for that, which may happen probably maybe 1 or 2% of the total requisitions for DMSA scan, most DMSA scans should be done later on. Yes.
Thank you very much, Dr. Lakshman.
Yeah, thank you, sir. It was a wonderful presentation by all the 4 speakers. And now we'll move on to the panel discussion. I invite Dr. Sri Krishna from Apollo Hospital to coordinate this session. Is
Thank
Sri
you.
Krishna available?
Yes, sir. Yes, sir. Available.
Yeah. Good morning, Sri Krishna.
Good
So
morning, sir.
Dr. Sri Krishna is a professor and HOD of Apollo Hospital, Apollo Medical College, Hyderabad. Is a senior pediatrician. I welcome to this session. You just coordinate this panel discussion. Over to Dr. Sri Krishna.
Sir, thank you very much, sir. At the outset, I thank Iaptcb for conducting an excellent session. Really, I'm following all the lectures. Really, they are extraordinary, I can say. Especially because UTI is the most common condition that we see in pediatrics, renal diseases. Plus, that is the one where a lot of mistakes we have noticed, even in our personal practice and even later also. So really, it's a wonderful session still now. And now just a panel discussion, common renal conditions beyond UTI. Let me share the screen. So we have all four expert panelists, the nephrologist, pediatric nephrologists already there. And now we are going to have the session. Just they are going to clear the doubts in other than UTI. Am I audible clearly?
Yes.
Yeah, yes.
Yeah, just a minute. Let me enlarge the screen. Okay. So the panelists are already here. We have delivered good lectures. Dr. Pankaj Deshpande, Dr. Nivedita Kamath, Dr. Himesh Burman, and of course Dr. Mehul Shah. Myself, Dr. Sri Krishna. I am HOD of Pediatrics at Apollo Medical College, Hyderabad. We'll start now. Here is a first case. A 5-year-old child came with eye swelling, seen by a general pediatrician who suspected nephrotic syndrome and ordered for simple investigation of CUE. Usually in day-to-day OPD, with the very first visit, if we order multiple tests also, there is a hesitation from the patients, and they always prefer the one which is non-invasive and very simple to do that. And this particular child, the CUE showed urine of just trace or 1+ protein. So that added in a confusion to the pediatrician. So my first question to Dr. Pankaj Deshpande, sir, should we ignore the report, taking it as a normal, or investigate further?
Okay, I think you've clearly mentioned the child has come with swelling of the eyelids and you are suspecting nephrotic syndrome. Now, the diagnosis of nephrotic syndrome is based on showing the presence of nephrotic range proteinuria. A urine routine test or a dipstick test, unfortunately, is a semi-quantitative test, which means that it will not tell you how much protein is actually coming out in the urine. So very simply put, if your urine is dilute, if your specific gravity is low, your urine reading will be low. If your specific gravity is high, your protein reading will be high. So in all the examples that I gave, if you look at the specific gravity, it was 1030, and that's why you were getting 1+ protein. The contrary is if you have 4+ protein and you've got a specifispecific gravity of 1010 or 1005, it might read negative or trace. So you are never going to pick it up. The second factor that alters the protein reading is the urine pH. So if you have alkaline urine, the urine protein reading is high. If you have acidic urine, the urine protein reading is low. So you will never be able to diagnose or say how much protein is coming out in the urine. And to get over this problem, you need to quantify the protein. Now in adults, they do a 24-hour urine sample or a timed urine sample, which is a difficult problem in children. So what we get away with doing is doing a urine protein creatinine ratio in the first morning urine sample. And if both are measured in milligram per deciliter, the normal ratio should be less than 0.5. So anything more than 1.5 is nephrotic range proteinuria.
Okay, sir. Really well said. So just when you suspect the disease, just don't depend on one simple test. And we know that there is multiple errors in many labs, even in a simple urine examination. So these are all very, what I have noticed in many labs, that they're very casual in doing the urine and blood stool test. And because this nowadays everything, this dipstick method has come, like everything is easy methods, so they are preferring that and giving these reports. So when you suspect it further, it is always better to evaluate the child further, not by not stopping here itself. Well said, sir. So in the same report, there are 10 to 20 pus in urine. Should we do urine culture or treat it as a UTI?
I think I already answered that in my presentation.
Yes. You have covered it, sir. Yes. So obviously he referred, still he is suspecting nephrotic syndrome or some major problem. So he referred the case to the nearby hospital, where the same child has a hypoproteinemia also, severe hypoproteinemia, and the nephrologist has confirmed as a nephrotic syndrome and advised to evaluate further. Here, we are traditionally, we read that every child of nephrotic syndrome, before starting steroid therapy, some basic tests need to be done. So we read this almost 20-25 years back when we were students. Is it hold same thing? That what is the role of Madam Nivedita? Please tell me, what is the role of urine culture before starting steroids, and how far they are really useful in your day-to-day practice of evaluating nephrotic syndrome for UTI?
So I think Pankaj sir has very clearly said this in his talk, and just to reiterate the same point, there is a likelihood of some pus cells being there in the urine, even in a child with nephrotic syndrome without UTI. So like we have all said in all the talks, that it needs, UTI diagnosis needs to have the symptoms of UTI. So at least fever or any other lower urinary tract symptoms. So in the absence of this, we would not routinely recommend doing a culture before starting steroids, because we do not suspect that this child has any UTI, even if there are a few pus cells in the urine. So that is not routinely recommended. Regarding the role of the MAN2 test, sir, you want me to?
Yes. Please tell the role of
MAN2 test. At least the Indian guidelines do recommend doing a MAN2 test. Most of the guidelines in other countries have done away with this because the risk of tuberculosis is not high. I think it is a very subjective practice what people follow. At our center, we continue to do a MAN2 test, and often we find that patients are MAN2 positive also. I mean, not often, but several times we do find they're MAN2 positive, and we give them the prophylaxis. But I don't know if the other panelists want to add anything to this. If there is a high risk of suspicion, if there is a family history, a history of contact, if there are any other clinical features to suggest, definitely a full evaluation of tuberculosis needs to be done. But I would like to hear from Mehul Shah sir and Pankaj sir and also Himesh what they would do.
Yes, even I want to continue it. Suppose this child came MAN2 positive and on evaluation, tuberculosis, evidence of tuberculosis or pulmonary tuberculosis. So obviously you are going to start ATT, but at the same time, what about his nephrotic status? Do you prefer to start steroids also? Dr. Mehul?
Yeah, I think Nivedita has already covered it, but yes, though there was an initial recommendation to do MAN2 test in all patients, like we are not doing it regularly in Hyderabad in all children with nephrotic syndrome unless there is a risk factor, malnourished children, or if there is a family history of tuberculosis. Now, regarding the question, once we have identified the child to have a strongly positive MAN2 test, be it more than 10 by 10 or more than 15 by 15 millimeter. We are going to take it, and there are no symptoms, meaning it's just a tuberculous infection and not a tuberculous disease. The chest X-ray is fine. The child does not have any other symptoms, and there is no family history of tuberculosis. We'll take it as tuberculous infection, put him on 2-drug anti-tuberculous agent, INH and rifampicin, and we usually start the therapy after 72 hours. We do not need to wait for 2 weeks time, which was the initial recommendation, and then start the nephrotic syndrome, because the reason for starting simultaneously is from our other, when we extrapolate management of children with disseminated tuberculosis or tuberculous meningoencephalitis, we do use steroids as well as anti-tubercular drugs simultaneously. So I think we can wait for about 72 hours to establish a good anti-tubercular drug level in the blood, and then start steroids after 72 hours. If it's only a tuberculous infection and not a disease. If it's a disease, certainly we would like to wait for about 2 weeks before starting.
Excellent, sir. Excellent reply. And now, after 15 days of steroid therapy, now the child came with a severe abdominal pain. Dr. Himesh, please tell me what are all the, we know that the steroids are known to give gastritis. Can we suspect any other problem? What are all the causes of abdominal pain in children with nephrotic syndrome? Dr. Himesh?
Yes. Am I audible?
Yes.
Yes.
So, causes of pain abdomen in nephrotic syndrome, this child who was treated with steroid and has come back after 15 days, and I'm assuming that child is not in remission yet. So in that scenario, one is the child may have developed a spontaneous bacterial peritonitis. That's common. So that could be one of the causes. If the edema has increased in some situations, so there could be some mesenteric ischemia that can lead to pain in these circumstances. So in increased edema situations where there is an intravascular hypovolemia, then as sir has already suggested, gastritis is one of the possibilities with steroid. And in sometimes steroids can also give rise to pancreatitis. So that also needs to be kept in mind. So this, I think these 4 points I would think. Then again, other relatively uncommon causes like complications like renal vein thrombosis and all also needs to be kept in mind if we have a compatible presentation for that.
Okay, sir. Well said, sir. Usually we presume that it's always gastritis, but it is not just gastritis. Think beyond that also when they are coming with repeated attacks of abdominal pain. So when do we, sir, same thing, when do we consider additional medication in children with nephrotic syndrome?
So to me, sir?
Yes, sir. Yes, yes.
Okay.
The additional medication in, you mean by?
Other than steroid therapy.
Other steroid sparing drugs?
Yes.
So other drugs are indicated, or second line drugs are indicated in 2 scenarios. First is if this is a steroid resistant nephrotic syndrome, which is currently defined by no response at 6 weeks of full daily dose of steroids. So we will that will be an indication for this one. And in situations of steroid-dependent and frequent relapse response, frequent relapse disease, where we have a higher threshold above 0.5 milligram per kg on alternate day. So in that situation, steroid-sparing drugs would be indicated. And if any dose, if it is we're maintaining, but there is signs of steroid toxicity coming in the child, then we would want to use steroid-sparing agents.
So the basically we treat the nephrotic syndrome in children almost as a nil lesion and steroid sensitive, isn't it?
Yes, sir.
Okay, okay. Thank you very much, sir. And we'll move on to the next case. A woman with 5 months pregnancy came to pediatrician with an ultrasound report of suspected renal anomaly of the fetus. So the parents came to us, and the parents said that they don't want to take any risk of having abnormal and diseased child. So the pediatrician is in dilemma of whether to consider continuation or termination of pregnancy. Obviously, it depends on the type of renal anomaly and what is its severity. So I request the Pankaj sir, what is the most common renal anomaly?
I think let's go back one step, because I'm
Yes.
very interested in the fact that you have written pediatrician is in a dilemma. No, the answer is there itself. The pediatrician cannot be in a dilemma. The decision has to be the parents.
Yes,
So
yes.
all that a doctor can do is place the possibilities in front of the parents and explain that this is what is likely to happen in the future. Now, some parents may say, well, fine, I have got children, I have got parents where there is a definite history of polycystic kidney disease or autosomal dominant polycystic kidney disease. There are anomalies on the kidneys, and I explain to them, and they say, at the most, what's going to happen? The child is going to have renal failure. So what? We'll transplant it. So it's not your decision to tell them what to do. It's the parents' decision to make a decision about their child.
It's true.
So,
It's true, sir. Many times, they cannot decide because
no, you
here
still wouldn't decide.
there are
No, no,
some
sir.
conditions which are correctable after the birth of the child.
No,
So
no, I'm
uh,
just coming to that. What I'm trying to tell you is that you cannot make a decision because you will be held responsible later. There are medical legal
yes,
aspects to it. The
yes, yes,
final decision has to be with the parents. You can sit 1 hour and explain to them the possibilities, but the risk taking always comes from the parents. You cannot make a
yes,
decision because the risk take, just like somebody invests in shares or in mutual funds. So it
yes,
depends on the risk appetite of the parents. So some
yes,
parents are very happy to say, let's continue whatever happens, while others are say, I don't want anything. So coming down to what you are asking, more important than that is how many ultrasound scans are abnormal in pregnant ladies. If you take 100 pregnant ladies, 4 of them are going to have an abnormal renal scan. So not
yes,
all of them are going to be having problems later on. So you need to find out whether it's a unilateral dilatation that is present, if it is bilateral dilatation which is present, if there is dilatation of the ureters that is present, if there is bladder abnormality that is present, and the most important aspect, which none of the books cover and which I want you all to remember, is presence of oligohydramnios. Irrespective
yes.
of whether the kidneys look normal or abnormal, if you have got oligohydramnios, you're dealing with problems later on.
Yes, yes, yes. It's a very important point, sir, where we see actually for it. But many times in the reports, they don't clearly mention about that factor. Yes, sir. And Nivedita ji, what is the outcome of common fetal renal anomalies? That means, can you tell that these are all the correctable problems and these are all the not correctable, so that we have to advise termination? You're not audible, Nivedita ji?
Can you hear me, sir?
Yes, yes.
So I think like Pankaj sir already mentioned, the finding of a renal anomaly on the ultrasound is not the issue. We need much more details to be known to make out what is the renal anomaly. So
Yes.
generally, the termination is suggested only when there is a life-threatening, that life cannot continue or there is no treatment at all. Most of the renal anomalies do not come in this category, that it is life-threatening. There is treatment, but of course with the risk of chronic kidney disease. So, or a requirement for dialysis, transplant, etc., which should be explained to the parents. I think just based on one scan, it may be very difficult unless there is like a very obvious thing, like say Arpkd with very large kidneys, or a third trimester scan which shows anhydramnios. Then such things are very obvious. But other than that, I think there are most of the conditions require serial scans and follow up, and most importantly, a postnatal scan before we can tell the parents conclusively what the condition is likely to be, and a complete evaluation in the postnatal period. So that is what is going to determine. If we look at the list of fetal anomalies of the kidney that are manifesting as antenatal hydronephrosis, what you will see in almost all reports is that 45% or close to 50% of them are transient hydronephrosis. So they have a very good prognosis, in the sense that they usually disappear as the child grows, and they are not of any anatomical significance or going to cause any renal dysfunction in the future. But this needs to be evaluated on serial ultrasounds. By only one ultrasound, it may be very difficult to counsel the parents. So we need to see what is happening to this antenatal hydronephrosis over a period of time. Associated things like sir has already mentioned about the amniotic fluid index, the presence of hydroureteronephrosis, of bladder dysfunction, all these need to be considered before advising. And if in the postnatal period also this child needs to be evaluated before we can conclusively say what is the anomaly and what is the mode of treatment.
Okay, madam. There, in continuation of your last thing, that the postnatal evaluation. So obviously, they soon after delivery they ask that should we go like simple hydronephrosis or like this problem. So the doubt comes when to refer or when to evaluate further. Is it soon after birth, or you can wait for 1 week to 10 days? Or you want to go for after 1 month of evaluation after birth? So is there any specific time or guidelines given to know that for the any postnatal evaluation for any child who was found to have or suspected renal anomalies in utero?
Yes, sir. So the guidelines of the Indian Society of Pediatric Nephrology for the evaluation of antenatal hydronephrosis have been published in Indian Pediatrics. I would urge that all of the pediatricians who encounter such patients should definitely go through that. What the guidelines recommend is that after day 3, like day 3 and beyond, a scan should be done in the postnatal period if there was antenatal hydronephrosis. This is because in the first 24 to 48 hours, we expect that there is physiological oliguria, that the child may not pass urine, and if there is a hydronephrosis, it may be missed, or the exact dimensions you may not be able to make out. So that is when a routine scan is recommended, and again a repeat scan at 3 months to see if it is persistent. If both the scans are positive for antenatal hydronephrosis, which is defined as posterior pelvic diameter of more than 10 mm, then that needs to be further evaluated up to infancy or 2 years. That is the recommendation. Now, in some scenarios where we expect that it could be a very serious abnormality like a posterior urethral valve, which should not be missed, some indicators may be there on the antenatal scan in the form of like say a persistently distended bladder, a keyhole bladder, oligohydramnios. Such babies need to be evaluated immediately, because you will need to do a scan and confirm it with the MCU and probably do a fulguration as soon as possible. So these babies, you need not wait for day 3. It could be done on day 1 itself. But in most other situations where it is not as serious, but it's just a hydronephrosis that is found, a day 3 scan and a 3-month scan is what is recommended.
Okay, well said, madam. Mehul Shahji, just tell, is there any specific renal anomaly found in utero that where you consider MTP, medical termination of pregnancy?
Yes, I think partly it has been covered, but there from pertaining to the renal system, if I can restrict myself to that, I think there are only 2 renal conditions where we would be worried about the poor long-term outcome of the renal function. One, as Nivedita mentioned, you have got enlarged and echogenic kidney, suggestive of autosomal recessive polycystic kidney disease, especially when associated with oligohydramnios, because we know this is a genetic condition and almost all children would eventually end up with end-stage renal disease, if not in the first decade, definitely in the early part of second decade of life, requiring dialysis and transplantation, which many families may not be able to continue the treatment. So that is one, enlarged and echogenic fetal kidneys, suggestive of autosomal recessive polycystic kidney disease. Or if you have got normal-sized echogenic kidneys with oligohydramnios, what we have learned over the last 15 to 20 years is that there are a lot of other conditions which can give rise to dysplasia, which can progress to renal failure or chronic kidney disease over time. So when there is oligohydramnios, it's a poor indicator even at 20 weeks of gestation. And the second major group would be baby boys in utero with bilateral hydroureteronephrosis and oligohydramnios. This baby boy with hydroureteronephrosis is very likely to be having posterior urethral valves, and when it is associated with oligohydramnios, it indicates fetal renal dysplasia, meaning the kidneys have not developed completely and hence there is oligohydramnios, and this child has a 90 to 95% risk of developing progressive chronic kidney disease in the first 5 years of life. So I would say when we practice parental counseling, these are the two conditions which we would be worried about, and tell them that the risk of renal failure postnatally is high. If the family is willing to take the risk and go ahead with the renal replacement therapy, we would continue. Otherwise, we would suggest that they may consider medical termination of pregnancy. Fortunately, this kind of situations happens maybe once or twice in a year, Sri Krishna. It's not that common. 98% of the time, we can reassure the family and ask them to continue and evaluate in a step-by-step manner, as Nivedita has mentioned.
Yes, sir. Well said, sir. That is actually, we need to go towards the positive side to the patients, because most of the time they come with a negative feeling and with a lot of fears from mother side, and all other family members think that whether to go for a termination. Nowadays it becomes so easy FTP, so they are preferring it. So all group of people will come into our chamber and start asking multiple questions. So obviously even the consultant also under pressure, what to say, what not to say. So there are very clear indications for a termination, and rest are all relative depending on the severity of the disease and parents' attitude. Thank you very much, sir. Now we'll move on to the next case. Here, a 6-year-old child, after an episode of dengue fever with severe hypotension, got treatment. During the recovery stage, they have diagnosed to have high renal parameters, and they sought the opinion of a nephrologist who suspected acute kidney injury. Here, I ask Dr. Pankaj, sir.
So Himesh hasn't answered the last.
Yes. Sorry, Dr. Himesh. So, what could be the cause of acute kidney injury? Is it just the hypotension alone? And nowadays we are using this word acute kidney injury more, whereas previously we used to read as acute renal failure. Is it the same synonymous, or both are different entities?
So, in this situation, we have a risk factor. The child has a dengue fever and there is hypotension. So that's a risk factor for decreased renal perfusion that we have. And that's the cause of the AKI. So, and regarding ARF versus AKI, ARF as in physiological terms means acute renal failure. So that means where the kidney has failed to maintain the homeostasis in the body. But we know that to reach that stage, there has to be significant insult that has to be happen in the kidney before they reach to the stage of failure. And when by the time we diagnose failure, then we have lost the window of any sort of intervention that can be done. And therefore, the insistence is on a early picking up where the stage of failure has not reached yet, and we have picked a child is in the level of injury. So for that, as per the Akin criteria, we will have a baseline. When we have a baseline creatinine, if there is a rise of 0.3 from the baseline creatinine, so that is the early indicator that's where it meets the diagnosis of definition of AKI. And in this case, first we have to see whether this hypotension has been there for how long, your creatinine has been elevated for how long, and what is the response of the kidney when we treat this hypotension and give a volume replacement. So based on that, whether it could be in a pre-renal stage or an acute renal stage may have set in secondary to the hypotension.
So what can a pediatrician do to minimize the risk of acute kidney injury?
So we need to know the risks of AKI. So we can have pre-renal causes, we can have renal causes, and we can have post-renal. So we need to be mindful of any possibility
usually
of
in emergency situations.
Yes, sir.
Many times if the patient come with the symptoms of shock, hypotension, we
Yes.
are more bothered about maintaining the blood pressure and perfusion. Now we think that kidneys will recover on their own, or kidneys may not be affected much. But still, do you advise anything extra apart from our routine care of hypotension and severe dehydration, hypotension, and shock? Do you think that early we could have done something more to minimize the risk of acute kidney injury?
So in setting of hypotension and shock, in that setting you're saying, so in that case, optimizing the circulation is the only thing we can do. But apart from that, we should be very mindful that we should cause no harm. That means in a case of hypotension, the other if we put other insult to the kidney, the risk of AKI increases. For example, if we are using NSAIDs in this situation, if we are using other nephrotoxic drugs, many of these children may need a CT scan or something. So where we're using contrast for that, so these all will increase the chances of AKI in this situation. So apart from maintaining the blood pressure and correcting the shock, we need to be mindful that we do not give any other nephrotoxic insult to these kids.
So always we should have an eye over the nephrotoxic drugs. These
Yes.
are one many times we feel that we shouldn't have given this medicine, or we should have avoided before. That's what I noticed. That
Yes.
are there any long-term risk in children recovering from AKI?
So shall I answer that, sir?
Yes.
Yes, so there is long-term side sequelae of the kidney AKI in children, but again that depends on the depends on cause to cause. There are certain causes where there are high chances of long-term sequelae, and whereas there are certain causes where there are lower chances of long-term sequelae. So causes like hemolytic uremic syndrome, rapidly progressive glomerulonephritis, these are some type of conditions where the long-term sequelae of AKI is much higher. Whereas in these kind of situations like diarrhea-associated AKI or sepsis-associated AKI, then the chances of reversal to reach normal renal function is very high. Having said that, all children with AKI needs to be followed up properly for their maintenance of renal function, new onset of hypertension, and growth. So we need to be follow these children for that.
Yes, sir. Well said, sir. Yeah, this aspect you have covered it already. That the awareness of risk factors for pediatrician, like NSAIDs for fevers, aminoglycosides, severe dehydration, and other things, and the use of diuretics also.
Yeah.
So you have covered almost all points. Thank you very much, sir. Very nicely described. Here, when a 3-year-old child came with growth failure and features of anemia resistant to routine therapy by pediatrician in a town. So he referred the child to higher center where they want to rule out the chronic kidney disease. I request Dr. Pankaj, sir, what are the presenting features of children with the CKD? Usually the most common features, what you have noticed?
I think the question kidney disease in terms of estimated GFR. Now, I think I don't need to tell people about estimated GFR. Schwartz formula is used to calculate the estimated GFR. Now, what everyone needs to understand is that most children with CKD are leading perfectly normal life in schools because we are not picking them up.
Yes.
Okay, they do not have any symptoms. So by the time they have presented to you with symptoms, you have already missed the boat because the symptoms come too late. When your estimated GFR is less than 20 or 30, that's the time you're going to get minimal symptoms. What symptoms do you get? Tiredness and lethargy. Now, every child who comes to your clinic has that. So how are you going to diagnose CKD? You're not going to diagnose. So that is the reason why, unless you monitor the creatinine, do at least when you do CBC so many times, you can get a creatinine done at some point, because you do not get symptoms. And I will repeat this 4 times. You do not get symptoms with CKD. So when your stage 1, stage 2, stage 3 CKD is there, you will not have any symptoms. This child has already got growth failure and anemia. Now, if it is CKD, you have already reached a stage where your GFR is far, far low. And that's when you are going to investigate and find out. So presenting features of children with CKD, remember, most children do not have any symptoms. So you have to pick CKD up. If they do present, it will be with either tiredness, lethargy, nausea at the extreme stage. Because when we talk of CKD, the image that comes up in our mind is a child who's sick, who's vomiting and needs dialysis. That's not true. CKD starts much earlier with no symptoms or minimal symptoms like lethargy, tiredness. Then you may, when you investigate, you might find anemia. Growth failure may be present, but most children of CKD may not have growth failure also. That comes up when your GFR is far, far low, less than 20 ml per minute. So I think the important point to remember is they do not have any symptoms. You have to pick CKD up. This is a condition where you don't wait for the patients to come, you pick CKD up.
So you are telling that many children just go unnoticed in the school. They go routinely to the school. So how to pick up these children who are not symptomatic, and so that we can do early initiation of therapy?
Correct. Now, before I answer this, can I ask a simple question to each member of the audience and the person who's questioning? What is your kidney function today? You don't know.
We think
correct.
Good.
The problem is not that we don't think about it. The problem, if you go and look at dialysis of patients, it's because nobody's done a creatinine ever. So the advice for every adult is also that you look for, and the same thing applies to children, which becomes a big issue when I say that this has to be done. But unless you check a serum creatinine and calculate the estimated GFR, unless you check proteinuria in the child by a protein creatinine ratio and check a blood pressure, you are never going to be able to say that the kidney function is normal for every child. So, and I think all this costs is less than 500 rupees per year. So we are not talking of expensive costs. So as long as you're doing this and these are
particular
normal,
test you want, sir? Which particular test you want?
Serum creatinine, and calculate the estimated GFR by the Schwartz formula.
Do
the urine protein creatinine ratio in an early morning urine sample and check the blood pressure of the child. So as long as this is done once a year in every adult and every child, you are not going to miss CKD ever.
Okay. Good. Really good point, sir. And which of the neonates are at a risk of developing CKD in future, sir?
Right. So let's go back to what I said. Why even neonates? Even before that, when I said that you have a child or you are called to a pregnancy where the ultrasound in the 6th month, 7th month has shown oligohydramnios. So we say oligohydramnios if the amniotic fluid index is less than 8. Less than 5 is severe oligohydramnios. So you have got oligohydramnios, let's say AFI is 7, and the child has no renal anomalies there. So when the child is born and the delivery goes perfectly normally, what do? We hand the baby over to the parent saying everything is normal, continue forever. This child does not continue forever. As Mehul rightly said, there are studies which have looked at oligohydramnios of renal origin which is present. All of them turned up with renal failure. And why do we not diagnose it? Because they present to adults.
Yes.
Dysplastic kidneys do not present to you. They present to adults needing dialysis. So in all these children, you need to do exactly what I said. Spend 500 rupees, get a serum creatinine, get a protein creatinine ratio done, and check the blood pressure. Often you will find that the creatinine is elevated in the first week of life. So it may be 1.2, 1.3. So are they going to get the renal failure in the first year? So what if you have missed it in the first week? No, you are going to miss it, because by the time you recheck it in 6 months' time, the creatinine is normal. This is because every baby is born with a GFR of 30 ml per minute, which improves to 80 ml per minute by 1 year of age. So this kidney maturation is going to make sure that your creatinine becomes normal. to go back to the previous, I'm sorry, I'm talking too much. Tell me when to stop.
No, sir.
So
No, sir.
going to the previous case that Himesh was talking about, please remember that in this state where the child is in a steady state creatinine reflex kidney function, in the acute scenario that you talked about last case, creatinine is a fairly unreliable marker because your creatinine today is reflecting what happened yesterday.
Yes.
So that's the place where you need to be careful about, because you might have a creatinine of 0.6 today, but the child is anuric because the creatinine tomorrow will be 2. This is reflecting what happened yesterday. So you have to be careful. Whereas in this case, it is a steady state. So if you monitor the creatinine will improve in the first year, but start deteriorating later. The proteinuria will come up first as the child grows in the rapid phase of puberty, and then you will have a rise of creatinine. So these are the neonates. So neonates who will develop CKD in the future, please look at history of oligohydramnios, any renal anomalies that may be, as Mehul already said in the beginning. So any renal anomaly that is present, especially posterior urethral valves, echogenic kidneys, these are all signs of dysplastic kidneys or polycystic kidneys. So they need to be monitored. So what are you going to do for them? The same triad that I said, spend 500 rupees, do a creatinine, protein creatinine ratio and a blood pressure.
Okay, sir. Well said, sir. Really enlightening us. Thank you very much for it. And here a local pediatrician in a remote area has seen a 6-year-old child with hematuria, puffy eyelids with hypertension. So obviously he suspected acute glomerular nephritis. Nivedita ji, just what is the best therapy?
1 minute, Dr. Sri Krishna. 1 minute. Is this the last case?
Yes, sir. Just 1-2 cases more.
Yeah.
What is the best therapy of children with this AGN in the clinic before sending them to hospital? And what and how much IV fluids to be given in an admitted child with nephrotic syndrome and acute glomerular nephritis? Of course, you can answer the first one. Madam, please unmute, madam. Nivedita ji. Not audible.
Is it audible now, sir?
Yes, yes.
Okay.
Yes.
So in a child who's come with a suspected acute glomerulonephritis or a post-infectious glomerulonephritis, there are 2 important things that must be looked at, because these can be life-threatening or can result in severe morbidity. One is, of course, hypertension, and the second, which is mostly asymptomatic, is hyperkalemia. So these are 2 things that we need to look at. Now we know that hypertension in a child with this acute glomerulonephritis is due to salt and water retention. So if possible, Lasix should be given because that is the drug of choice, because the fluid and salt retention is what is causing the hypertension. And we know that the hypertension can rise rapidly and can cause hypertensive encephalopathy or CCF. So considering that you are waiting to send this child to a referral hospital or something, if possible, to give IV furosemide 1 dose. The second thing is hyperkalemia, because again, hyperkalemia can be there even in the absence of renal dysfunction. So the creatinine may be normal, but potassium may be high. So to always look at hyperkalemia, preferably a lab value, and if it is high, to look for ECG changes and treat this before shifting the child, because we know that hyperkalemia can also cause arrhythmias at any point in time and cause life-threatening issues. So these are 2 life-threatening problems that must be addressed before shifting any child with a suspected PSGN.
And many times when we admit the cases of nephrotic syndrome and acute glomerular nephritis, we know that first 24 hours is the period of evaluation than the aggressive medication. So, but our problem with that is our patients many times have the habit that if you admit the patient, saline should go on, some IV fluid should go on. So the doctors are always in a dilemma, especially in small centers, in towns especially, they face a problem and they keep asking what sort of IV fluids can we give, or is it necessary to give any fluid to, through IV in a case of nephrotic syndrome or AGN?
So I'll talk about the AG and PASA. So like we said here, the issue is that there is glomerulonephritis, there is inflammation of the glomerulus, as a result of which there is salt and water retention, which is causing the hypertension. There may or may not be associated renal dysfunction or an abnormal creatinine. So in this situation, it is very important to restrict salt and water. So we would, unless the child is sick due to any other cause, then we would not recommend to give IV fluids. Salt restriction and fluid restriction would be advised. So usually we restrict fluids to about half the maintenance or 2/3 of the maintenance and monitor the urine output simultaneously. So, and we are going to give oral furosemide or IV furosemide, and we are going to look at the urine output response. Also, the clinical evaluation to see if the child is in fluid overload, the child has an abnormal creatinine, you may want to restrict the fluids further. So there is no real indication to give IV fluids unless the child is sick, not able to take orally due to any other reasons.
Yes,
in a
sir.
child with nephrotic syndrome, it depends on what situation the child has come in. Suppose the child has come with features of hypovolemia, you may need to give, which is quite, we see quite often, especially when they come with infections, they have features of hypovolemia in the form of tachycardia, cool peripheries, poor peripheral or sometimes central pulses also, and blood pressures usually may not be very low unless there is sepsis. So in these situations, we may need to give some IV fluids in the form of a bolus of normal saline. And if there is no improvement and if there are all features of hypovolemia, we also consider giving albumin. So it depends on what this situation the child has come in. If the child, what most pediatricians or sometimes our residents are worried about is when the child is massively edematous, can we give fluids? So there is, it depends on the volume status of the child, because maintaining
Yes.
volume status should be the first goal of any therapy. When we see like ABC,
Yes,
so airway breathing, there is no issue in a nephrotic, but circulation is the next thing that we need to maintain. So if a child has come with features of hypovolemia, then definitely fluid should be given, and we should not, like we treat a child with sepsis, you should not keep on giving fluid, crystalloid boluses like 40 or 60 ml per kg. So early institution of albumin, because we know that the hypovolemia here is probably associated with severe hypoalbuminemia as well. So early use of a colloid like albumin may help to restore the volume status. Rarely we see children with nephrotic syndrome coming with fluid overload. It may be present when there is abnormal creatinine or some other complication of nephrotic, in which case we need to restrict the fluids. Otherwise, most often we give them normal fluids, and you need not give IV fluids unless the child is sick.
Yes, madam. This confusion will be there many times with the PGs, especially in the night duties. When the nephrotic syndrome gets admitted, they think that the child is already overloaded with fluid, so they need not receive any IV fluids at all. But they are missing the blood pressure and other important parameters, so that need to be considered for giving the IV therapy. Thank you, madam. And here, 2-year-old child admitted with 3 days history of high-grade fever without obvious focus. As a part of routine investigation of fever profile, CUE done and urine culture was sent. The fever came down in next 2 days. Mehulji, just please answer this. Though already we have covered infection extensively, this is a one which is confusing and very commonly we see in day-to-day practice. The fever for this child has come down in next 2 days. And meanwhile, the reports CUE is normal. After 3 days, the urine culture showed multi-drug resistant Klebsiella of more than 1 lakh per cc. These are actually cases which I have seen. And what should be the next step? First, can we neglect this report? Because the child became all right, no fever, and but at the same time, this report of documented report of showing Klebsiella in the urine, that too multi-drug resistant. So always the pediatricians are scared to think whether to avoid antibiotics. So can we neglect this report?
Yes, I think part of it, as you mentioned, Sri Krishna, has been covered both by Himesh and by Pankaj. If the child is clinically better without any antimicrobial therapy, the complete urine examination is unremarkable. We are pretty sure that this child does not have a urinary tract infection, because a child who has got pyelonephritis will not get better by himself or herself without the institution of antimicrobial therapy. So that is one. Yes, I would ignore the report. And for this one reason and second reason, as Pankaj had very nicely elaborated, how was this urine sample collected? Was it collected in a clean manner, in a clean container? At what temperature was it stored, and at what temperature was it transported, and how quickly the lab person has inoculated on the plate? So I think there are a lot of reasons why we end up getting a false positive growth. So based upon the clinical situation, yes, I would ignore the culture report and observe the child.
Here, one question is, usually we know that the E. coli is a common commensal, so the count is important. Whereas the colony count for Klebsiella also important to see for 1 lakh.
Yes, I think that's a good question. Certainly, there have been some studies where they have found that certain bacteria are not able to mount the same amount of inflammatory response to infection as compared to E. coli. Klebsiella, Pseudomonas, and Enterobacter, they do not lead to inflammatory response. So you may not get pus cells in the urine, but the colony count should be significant in the manner it has been collected. So I would say, yes, colony count of more than 10⁵ CFU per ml in a clean cat sample for all organisms should be considered significant. Yes. But to remember that Klebsiella, Pseudomonas, and Enterobacter may not be associated with significant pyuria in about 25 to 30% of children, as compared to only 10% with E. coli. So that's one point I would like to share. Yes.
Okay, well said, sir. So obviously, do you treat with higher antibiotic? It depends. You have answered it already. So, just a final word. Any particular recent advances you have noticed in pediatric nephrology? Of course, this is a vast answer, but still, I want to say just 1 or 2 points from each speaker. Dr. Pankaj, sir.
I think the more we know how little we know holds true here. And I think we need to go back to the basics. As I said, we do not check basic kidney function. We do not know our own kidney function, so forget about our patients. So let's start doing, these are basic things, because what has been realized, and I think it is going to come out even more and more, is, for example, we have never done a Dmsa scan on you, sir. So we do not know whether you have got completely pristine normal kidneys or whether you were born with abnormal kidneys. And this is going to, so as Mehul put the slide up saying 17% reflux nephropathy, that has changed over a period of time, not because we are treating UTIs more effectively or we are picking up reflux more effectively, but because we have realized that it is dysplasia which is causing these problems. I will give you umpteen examples of patients who have had single episode of a urine infection, were diagnosed to have grade 4 VUR, operated immediately, and they are ending up with renal failure today. So why are they getting into renal failure? Because the nephron number was wrong, was less at birth. And unless we monitor these patients, we think end of reflux, end of story. No, it does not begin that way and does not end that way. So I think 500 rupees, please spend for it. Creatinine, protein creatinine ratio, and blood pressure is the message that needs to go out for everybody.
Yes, sir. Thank you very much, sir. And Dr. Nivedita ji, please unmute. Please unmute.
Can you hear me, sir, now?
Yes.
So I think I'd like to echo what Pankaj sir has already mentioned. I think we said it in UTI diagnosis and management as well, but in all kidney diseases, most importantly, because kidney diseases, unlike diseases of other systems, don't come with specific symptoms. So a high risk of suspicion is important, and following up the patient who are at high risk is important. So right from the antenatal scans, we see very often that antenatal scans are done, but nobody has seen them. They are seen, but they are not followed up in the postnatal period. They are followed up in the postnatal period for some time, but after that, patients have not been advised as to what is to be done. Similarly, for cases of AKI, like Dr. Himesh was saying, there is definitely evidence to show that they have sequelae in the form of abnormal creatinine, of having proteinuria, hypertension. So all these need to be monitored. So for every child who comes above 3 years to a pediatrician, I think a blood pressure should be checked so that we can detect these problems early. In all high risk, I think follow-up is important. Very often it is the onus is on the pediatrician or the nephrologist, because the parents feel that our child is okay. Everything is fine, but we need to spend that time to inform them that some of the problems of kidney disease can only be detected on investigation, and may not, when it is found in clinical as clinical signs and symptoms, it may be too late. So I think emphasis on prevention and emphasis on early pickup and follow-up.
Yes, sir. Thank you, madam. Dr. Himesh Burman.
Yes, I have nothing much to add. Actually, this on advances, but actually, not talking about advances, we need to implement whatever is known already. We have a lot of things to be done. And as Madam Nivedita and Dr. Pankaj has already pointed out, follow-up is very important. We identify the children who are at higher risk and follow them up properly, pick them up early. Measurement of blood pressure is one very important. All children coming here, coming to OPDs do not get their blood pressure measured normally. So that is one opportunity we are missing to pick up any kidney problem. Even when children are known to have kidney problem, when they come for follow-up, we do not regularly measure blood pressures for these children. So measuring blood pressure is one simple thing that we can incorporate in our practice. Monitoring growth and periodic monitoring of creatinine. These would essentially pick up a lot of cases.
Okay. Thank you very much, Dr. Mehul Shah.
Yeah, I think not take a lot of time. As you said, it's a vast topic. Just a couple of points over here. One thing is of whole exome sequencing and next generation sequencing. I think that has helped us understand a lot of problems which we knew clinically, but I think the whole exome sequencing has solved the puzzles of a number of mysteries which were identified by the clinical neprophysiologists 60, 70 years ago. So I think that has been one major development in the last 10 years, I would say, especially to assist us in better management of some of our patients. Second thing is the availability of higher immunosuppressive agents, including rituximab, for some difficult to treat nephrotic syndrome patients. Third, I would say is the importance of using isotonic fluid in the hospitalized patients, which we were not doing until, say, maybe about 10 years ago. We used to use hypotonic fluids like Isolite P, but I think we know there has a danger of causing hyponatremia, symptomatic hyponatremia, that is being replaced with isotonic fluids, with balanced fluids also being available. And I think just one last point, in addition to what Pankaj said regarding the neonates who are at risk for future CKD, besides the fetal renal anomalies, I think to share with the pediatricians and our neonatologists, children who are born IUGR, small for gestational age, and those who have been extremely preterm, and those who have recurred from AKI. These are the three subgroups of neonates who would need long-term follow-up, because we have realized that these children, especially small for gestational age babies, are at a higher risk for developing proteinuria, hypertension, diabetes, and chronic kidney disease. So I think healthy measures in terms of dietary modification, increasing physical activity, and monitoring them with the measures which Pankaj and team has mentioned is becoming very important, and not to leave them unhealthy when we transfer them to the internist. Thank you.
Okay. Thank you very much. Really, very useful advices are given. I'm following right from first lecture onwards, including this panel discussion also. I thank all the panelists for your active and participation and very valuable suggestions you have given. Thank you very much. Over to Dr. Lakshman, sir.
Thank you, Dr. Sri Krishna. It was a wonderful panel discussion on all overall problems. Sir, Dr. Mehul Shah is there now?
Yes. Sir, yeah, doctor.
I have one question, sir. Like grade 3, grade 4, VU refluxes. If you left with medical treatment, what would be the outcome, sir?
Yes, I think this is the gray zone or the controversial zone of urinary reflux grade 3 to grade 4. The reported literature as well as our own experience says that there is a 50 to 60% possibility of this moderate grade reflux to resolve as the child grows. And as long as the child is not having any breakthrough febrile urine infections or there are no development of new scars, we can safely continue with medical measures at least till 2 to 2.5 years, and even observation after 2 to 3 years, and monitor them maybe every 1 to 2 years with DRCG. I would say even 2 years, not even 1 year, and wait at least till about 5 to 7 years to see whether it is resolved or not resolved. So grade 3 to grade 4 reflux, there is a 50 to 60% possibility of spontaneous resolution. As the bladder grows in capacity, the ureter does recreate its submucosal tunnel, which is required for the anti-reflux mechanism. So I would say there's a good chance. Main thing is there should be no breakthrough febrile urinary tract infection. I think that is the bottom line. Yes.
The case of like around 15 years boy with a right-sided reflux grade 4 with renal scarring in the upper pole.
Right.
Left kidney is normal. So what like they have consulted so many doctors. They came to me and asking for nephrectomy on that side. So what do you suggest, sir? Hypertension is not there, normotensive.
Okay, and the reflux is still persisting, or the reflux has resolved?
It's still persisting, sir.
Okay, so I think this is again going to be a gray zone over here. One thing is, how many times has the child had recurrent urinary tract infections, and when was the last episode? That's one. Second thing is, what is the function of the left kidney, which is the damaged kidney? Is it less than 10%? Is it 10 to 20% or more than 20%? And third thing is, are there any established features of reflux nephropathy in terms of hypertension and proteinuria, or even microproteinuria, microalbuminuria? So now if there are no urine infections, well, we don't need to, no urine infections, no hypertension, no proteinuria, and the kidney function is more than 20%, I would suggest probably we should go ahead and re-implant this ureter, because the possibility of this reflux resolving beyond 10 years of life, grade 4 reflux, is less than 10%. So why leave it and expose the child to future infections, because it can happen later on. Not only that kidney, but even the other kidney may get affected. So more than 20% kidney function and persisting reflux in a 15-year-old, we should re-implant it. Now, if its the function is less than 10%, then, and the reflux is still persisting with grade 4, I think the option of giving nephrectomy is a valid option, because one, we are not going to improve the function by doing a re-implantation, and this child has a risk of developing hypertension and proteinuria down the road, where even after re-implanting, this child may need nephrectomy maybe at 25-30 years. So I think less than 10% function, definitely nephrectomy. If it is between 10 to 20%, I think that is something we counsel the family. One, we should probably either re-implant, or with our surgical team, we can do a Dexel injection and see how things are. And in case if the child develops complications future, then go for a nephrectomy. So I know it's not a clear answer, but we look at the split renal function and the establishment of reflux nephropathy parameters at this point.
Yeah, thank you, sir.
Thank you, Dr. Thank you, Dr. Lakshman. Thank you very much. It was a wonderful match, sir. All the batsmen had made more than double centuries. Wonderful, sir. The opposition team is totally knocked out, and it's such a wonderful program. We thought nobody should miss it. That's why it's been recorded in YouTube, and also it would be printed in our journal. And I'm sure many of us will again revisit to this YouTube presentation. And I request all the faculty members to send their abstracts to Dr. Mehul Shahji, so that we can print it in our our next book. Now, Dr. R.S. will let us release the journal with the hands of, by the hands of our cricket team manager and man behind the game, everything. So I request that RSV see that the journal is released by our Dr. Mehul Shahji.
Thank you, sir. Thank you. So this is like the post-match ceremony. The match is over and we have a short ceremony towards the end. Mehul Shah, sir, request you to just say a few words after I just show the edition, and I'll just share the screen and show you our journal. And this is a small effort from our end to ensure that all the pediatricians are up to date with whatever is required for their everyday clinical practice. It's also very, very useful for postgraduates. These 2 pages are literally essay questions in your exams. So this journal is coming out every month and is a promise that it will coincide with the symposium that we do. So this is the March issue, and it has a message from the editor-in-chief, Dr. Sanjay Srirampur, the president's message and the secretary's note. And these are the contents. We made sure that it's not very voluminous, a small update, and is meant to improve your pediatric practice. So we have one lead article on improving early breastfeeding rates in health facilities by Dr. Arun Gupta. He's the central coordinator of BPNI, and a very important program coming up by IIP Twin Cities branch on breastfeeding. It's called Breastfeeding First. And this program is getting launched in this month, and this is a lead article in a build-up to that event. We have 2 wonderful articles which are position statements of IAP, and these position statements are very, very critical in our day-to-day practice. One is on COVID vaccination. A lot of apprehension now and a fear that we've taken the vaccine, still got affected in the 3rd wave. So not sure how much it's going to protect children, a lot of doubts in everyone's mind. And this is a statement from IAP's ACVIP team, and Dr. Sanjay Srirampur and Dr. Srinivas Kalyani have authored this particular article. And this tells us very clearly why IAP is recommending COVID vaccination for children. And this will help you answer all the queries from parents. And these are very clear recommendations. The next one is on breastfeeding in COVID-19, another important area affected by COVID, and the IYCF chapter recommendations on why and how do we deal with breastfeeding in the COVID scenario. Then we have take-home messages from the Symposium on Pediatric Pulmonology. Dr. Srinivas Jakka and Dr. Indu Khosla have shared something very interesting on functional respiratory disorders and pearls in pediatric sleep. And these are very interesting articles. I myself was amazed at how much knowledge is present in this domain of pediatric sleep. And there are so many issues and so much insights by Dr. Indu Khosla. Then we had 4 clinical cases presented, and these are abstracts of those cases compiled by Dr. Srikanth. So a 10-year-old with fever, cold, cough, and gross hematuria by Rainbow Hospital. Later on, this child needed live related kidney transplantation, and a very good case discussion on that. And a 3-month-old with pallor hepatosplenomegaly from Nilofer Hospital, and a 13-year-old with progressive pallor and splenomegaly from ESI Hospital, which was found to be a idiopathic portal hypertension due to non-cirrhotic portal fibrosis. And then a glimpse of what IAP Twin Cities has done in the past 1 month. We have done a lot of advocacy on pulse polio. We strongly advocate, support, and endorse the pulse polio campaign of Government of India. Then we've had one on cancer awareness, wherein we went to the Zilla Parishad High School in Manikonda and then spread awareness on importance of cancer and how to detect it early. And a snapshot of our online events. The last month has been ravaged by COVID across the country, and we've been doing all these events online. So these are just some snapshots, and it always gives back good memories for us of what we have done through the month. So we had the release of the journal by our Honorable President of IAP, Dr. Ramesh Kumar. And we had the Vice President of Central Zone, Dr. Radhakrishna, the State President, Dr. Sanjay Srirampur, and all the members of the respiratory chapter who had joined us for the release of the journal. Then we had the clinical meeting again online, and these 4 clinical cases were presented, and a symposium on pediatric pulmonology with Dr. Indu Khosla, Dr. Subramaniam, Dr. Deen Dayal, Dr. Suman, Dr. K.V. Rao, who coordinated that meeting, and a wonderful symposium with very good insights on common as well as rare topics of pediatric respiratory medicine. And all smiles in this particular the page from the PG clinics. It was an online meeting on a very interesting case, which was discussed by Dr. Tilak Chandrapal, Dr. Vijay Kumar, and also insights by Dr. Ajay Mohan, Dr. George, and the postgraduate from Gandhi Hospital. A very good, interesting case. You can find all these on the YouTube link. This is present. So you just have to click it like this, and then it will lead you to that particular recorded session. And the last page is the announcement of IAP Central Zone Conference. We invite you all to block your dates between 10th and 12th of June 2022. The venue is Hyderabad, and the hosts are IAP Twin Cities branch along with our state branch. And we cordially invite all of you to please join us. We promise our best efforts to make it a memorable conference for all of us. And we look forward to host you with our warm hospitality and ensure that academics will be a top priority, along with a lot of fun and entertainment as well. So that is our journal. And thank you everyone. And just a few words from Dr. Mehul Shah. Sir, over to you.
Thank you so much, Dr. Sri Krishna RSV. Thank you so much, Dr. Bhaskar Garu, Dr. Lakshman Garu, Dr. Sri Krishna, and the entire IAP Twin City branch. I think it has been a wonderful session, not only for the participants, but I can say at least for me, and I'm sure for the rest of my team faculty, because it's always you keep on learning when we need to prepare for the symposium. And sometimes, as Pankaj said, we first need to unlearn what we have learned and then put in some new information. I think so. Thank you for the opportunity. And secondly, I know that Twin City branch of the IAP over here has been doing remarkable work in academics, and all of you are very busy practitioners, and despite that, getting some time out and working for the interest of the children and the pediatricians, I think it's very, very applaudable. And cheers to the entire team, and best wishes to everyone. And finally, I would like to thank my friends Pankaj, Nivedita, and Himesh for agreeing to be part of this. Hope to have you all back again and again for the benefit of our pediatricians over here. Thank you once again. Thank you. Thank you.
Yeah. Thank you, sir. Honestly, we are looking forward for another academic meet with the same team. It's really so much interesting. From morning 9 o'clock until now, 3 hours, 30 minutes passed away just like 30 minutes. Credit goes to the super batsmen of all the 4 batsmen. Thank you so much, sir. And special thanks to the participants, because without them, whatever we do, it's of no use. So honestly, my special tributes to our participants and to all the faculty members. Thank you, sir. Good day.
Thank you.
Yeah, is Dr. Vamshi here? Treasurer for vote of thanks. Dr. Vamshi is not around, so I'm just proposing vote of thanks on behalf of IAP Twin Cities branch. And it's a pleasure, sir. We started with a wonderful theme of cricket, and there have been bouncers, slow balls, googlies, and all the batsmen have dealt all of them extremely well. It's been a very exciting match as well. And our sincere thanks to all the batsmen who have faced these balls and ensured that you finish the innings not out. Dr. Lakshman Garalpati has been wonderful coordinating the entire event, and our appreciations to our own Sri Krishna sir, my teacher as well. Excellent questions which we face on a day-to-day basis. And these are questions which we feel, if Dr. Mehul were in front of me, I would have asked him, what should I do in this particular case? And excellent questions which have been very nicely explained by the faculty. Thank you, everyone. And we're very fortunate to have you preside over the journal release. And I'm sure we'll capture all the good points from the symposium in the next journal. Thanks, everyone. And I will catch up with you again over the next academic session.
Thank you.
Thank you.
Thank you.